Good morning, everyone, and welcome to our 2021 John Scholz Stroke Education Conference. I'm going to get started now since we have a full schedule and want to stay on time. I appreciate everyone getting up early to attend this conference, and I think you will really enjoy the experience we have for you over the next 4 hours. This is our 21st conference, which we have conducted over about 24 years. And I want to, first of all, thank Dr. Kate Smith, who almost single-handedly put this conference together and has just done a fantastic job. And Kate is with the Delaware Academy of Medicine, which has been partnering with us at the Delaware Stroke Initiative for many years to put on this conference. If I could have the next slide, please. John Scholz was involved with the Delaware Stroke Initiative from the beginning, some 23 years ago, and John was an excellent professor of physical therapy at the University of Delaware and spoke many times in the early years of our conference, and just was an excellent person. And unfortunately, John contracted pancreatic cancer and valiantly fought it for many years before unfortunately losing his battle. So it is a real nice memory for me to every year think about John, and because of all of his effort on behalf of the Delaware Stroke Initiative and Delaware stroke patients, we have named that conference after John. This is a continuing medical education conference, and we have been designated to provide 3.75 hours of Category 1 credit to physicians, and we also are designated to provide nursing credit and credit for physical and occupational therapy. All the attendees will receive within the next 30 days at the end of the conference an email. That email will be a link to the evaluation. When you complete the evaluation, you will be able to print out your certificate of CME. As I mentioned, this has also been approved for 3.75 hours for occupational and physical therapy. The planning committee has no disclosures. Dr. Awad is a member of the advisory board for MedRhythms, and all other presenters have no disclosures. So without further ado, we'll get started. Because of this being, okay, thank you. Okay, so as everyone probably knows by now,
my recording is going on now. Soon it will be.
Yeah, as everyone knows by now, you can ask questions at the bottom of the Zoom screen. So please, anytime you have a question, type it into the question and answer box. At the end of each presenter's talk, we will have several minutes left for them to answer as many questions as possible. If they're not able to answer all the questions live, they will be able to answer the questions offline through the question and answer box. So hopefully everyone's question will be answered. But because of the virtual nature of this conference, we are having a couple of the speakers give their talks in a recorded fashion. Dr. Saudi, I think, is getting a couple extra minutes of beauty sleep this morning. So we have his talk recorded, but he will be available at the end to answer questions. So I would like to introduce Dr. Sadako Saudi. I was looking through our brochures trying to figure out which conference this was, and I just pulled one out of my file cabinet, and it was the 2013 one, and as it turned out, that was one of the many talks that Sadako has given for us. Dr. Saudi is an associate director of neurointerventional surgery at Christiana Care. He earned his medical degree and completed his internal medicine internship at Hahnemann University in Philadelphia. He completed a residency there in diagnostic radiology, and he went on to complete dual fellowships in diagnostic neuroradiology, in interventional neuroradiology, endovascular neurosurgery at the University of Pennsylvania. Dr. Saudi's clinical expertise includes minimal invasive procedures on the head, the neck, and the spine, Sadako, I know from many years of personal experience, is an excellent clinician, and he is also an excellent speaker. He's going to speak today on aneurysms and subarachnoid hemorrhage, and this is just as a real quick side note, somewhat appropriate. Our first first keynote speaker at our first conference, which was 21 conferences ago, was the then senator from Delaware and the current president of the United States, Joseph Biden, who spoke about his own experience with an aneurysm. So this is a very appropriate talk. So without any further ado, we'll begin Dr. Saudi's talk.
Good morning. I'd like to thank the Planning Committee for their kind invitation to speak to you regarding advances in endovascular treatment of brain aneurysms at this year's John Scholz Stroke Conference 2021. I have no pertinent disclosures for today's discussion. I want to focus on a couple of issues: aneurysm size and associated risk of rupture, utilization of the Facey score to predict aneurysm rupture and help guide treatment between conservative management with serial imaging versus intervention or microsurgical clipping. Discuss briefly symptoms and also talk about treatment options and associated risk profile. With increased imaging of the brain and intracranial circulation, we are identifying more unruptured intracranial aneurysms that are asymptomatic. And these aneurysms are challenging. The balance is between treatment and observation. In terms of understanding whether a patient should be observed or treated, we need to understand a little bit about the natural history of intracranial aneurysms. The best data set that we have is the International Study of Unruptured Intracranial Aneurysms. This was a prospective observational study in which 4,060 patients were screened. There were more than 60 centers in the United States, Canada, and Europe. 1,692 patients were treated, whereas 1,917 patients underwent surgery. And surgery refers to microsurgical clipping. 451 patients underwent coiling. The key is that risk of rupture increases based on size, and risk of rupture increases in patients with aneurysms in the posterior circulation, meaning aneurysm affecting the vertebral arteries, basilar arteries, and the posterior cerebral. What they found is that when you went from smaller to medium, large, and giant aneurysms, the risk of rupture increased. Medium aneurysms, which was defined as 7 to 12 millimeters, had a 5-year rupture rate of 15%. Aneurysms smaller than 7 millimeters, rupture rates were 2.5%. Once you get to larger aneurysms, the risk of aneurysm rupture was significant. One of the major criticisms that I have regarding this study are the limitations. There was a significant selection bias. Of the screened patients, 4,000 patients, only 1,900 were treated. That means more than half of the patients were removed from the study before they were enrolled. That means that high-risk patients were probably treated rather than enrolled in this observational study. Additionally, cavernous aneurysms, which have very low probability of rupture, were included in this study. Cavernous aneurysms occur below the intracranial or intradural compartment. These patients represented 12.4% of all untreated patients. This bias of both excluding high-risk patients and including low-risk aneurysms likely results in an underestimation of aneurysm rupture rates. Another cohort study is the Unruptured Cerebral Aneurysm Study in Japan, UCAS. This was prospective, And in this study, 5,720 patients with 6,697 aneurysms were enrolled in a 3-year index period. 3,647 were untreated, and 3,000 were treated with either clipping or coiling. The overall annual rupture rate was approximately 1%. Additionally, when we look at this Ucas study, we see that the aneurysm rupture size centered around 7 millimeters, but there was a significant number of patients with aneurysms rupturing below 6 millimeters and down to 4 millimeters. The mean size was less than 7 millimeters. In addition to the size, location seemed to be important. Anterior communicating artery aneurysm ruptured on average at 5.5 millimeters. Posterior inferior cerebellar artery aneurysms ruptured on average at 4.2 millimeters. Other aneurysms such as posterior communicating, ICA, MCA were just below 7 millimeters. So location is important, and aneurysms smaller than 7 millimeters down to approximately 5 millimeters were at risk of rupture. The other thing we want to do is try to figure out which patients should or shouldn't be treated in an organized manner. One clinical treatment tool that is helpful is the Facey Scale. The first step in using this Facey Scale is excluding patients with a family history, polycystic kidney disease, aneurysm-related symptoms, including sentinel hemorrhage or mass effect. Once you exclude those high-risk patients, you can use this chart to help guide treatment. So some of the important variables include genetic risk factor, such as Japanese or Finnish descent, presence of hypertension, age greater than or equal to 70, aneurysm size of 7 millimeters or greater, subarachnoid hemorrhage from another aneurysm, as well as the location of aneurysms. As previously noted, anterior communicating artery, posterior circulation, and posterior communicating arteries had the highest risk. Once you add up these numbers, it can help guide whether patients should be counseled regarding treatment versus conservative management. Some of the risk factors for aneurysm growth in unruptured patients are listed here in Table 4. Female sex, cigarette smoking, aneurysm growth was associated with increased risk. Age of diagnosis, older patients had higher risk of yearly rupture. So after reviewing that discussion of observation, let's look at patients in which we want to consider treatment. There are 3 different techniques for aneurysm treatment. The first is extraaneurysmal treatment, intraaneurysmal treatment, and treatment of the neck or the parent vessel. Walter Dandy, starting in 1937, described some of the earliest experience with extraaneurysmal treatment or microsurgical clipping. This technique has evolved over time with use of surgical microscopes, smaller craniotomies, and improved skill sets and improved experience, as well as improved visualization of the aneurysms in non-invasive images for pre-procedural planning. Here you can see the image on the left. There is an outlined posterior communicating artery aneurysm. You can see the vessel is extremely red, irritated, has macrolobulations, and you can clearly see the wall is thin. A lot of times intraoperatively, you can see blood flowing through these aneurysms. The normal blood vessel, which is a little bit diseased and atherosclerotic, can be seen in a more yellow-white appearance versus the red aneurysm. The schematic diagram to the right shows the trajectory of a microsurgical clip being placed along the neck of the aneurysm and the parent vessel's anterior communicating and posterior communicating arteries. After placement of the microsurgical clip, visually the posterior communicating artery is remaining patent, the anterior choroidal artery is separate, and you can see the microsurgical clip obliterating the neck of the aneurysm. This is the pre-image, that's the post-microsurgical clipping. In terms of microsurgical clipping or open surgical repair of aneurysms versus endovascular treatment of aneurysms, we have been guided largely by the Isat trial, as well as trends over time. So the Isat trial is the International Sub-Arachnoid Aneurysm Trial. In that trial, ruptured aneurysms tended to have better outcomes. So 7% absolute reduction in major complications versus microsurgical clipping. You can see pre-2002, when ISAT, before ISAT was written, you can see the number of patients undergoing coiling was approximately 10%. After the ISAT paper, ruptured aneurysms were being treated much more frequently with coil embolization. You can see similarly, unruptured aneurysms went from a smaller percentage before 2002 to after 2002, where it's 61%. It is variable, but in many institutions, endovascular treatment of unruptured aneurysm is between 60 to 80%. Endovascular treatment for ruptured aneurysms is probably greater. In 2015, you can see the increase over time from 2001 to 2015 with endovascular treatment of aneurysms being significantly increasing after the ISAT study, microsurgical clipping remaining relatively similar. The total number of aneurysms being treated is also increasing. This may be a result of increased imaging and identification of unruptured aneurysm. After extra-aneurysmal treatment, which means microsurgical clipping, another approach is to actually repair the aneurysms from inside the blood vessels. The first trials were performed in the 1980s, and you can see this gentleman, Guglielmi. He is the one that helped pioneer endovascular treatment, or something we call coil embolization, placing coils inside of the aneurysm through the blood vessels. The main approaches we have include primary coiling, which is to take a small plastic tube or a microcatheter into the artery, into the aneurysm, and placing bare metal coils. Additionally, when aneurysm's neck are wide, the opening from the aneurysm into the parent vessel is wide, we can sometimes intermittently inflate a balloon to help push the coils into the aneurysm. In patients that are candidates for antiplatelet agents, generally unruptured aneurysms, we sometimes place a stent, which is a metal scaffold across the neck of the aneurysm, in addition to the coils. Some of the considerations we have are, what is our access site? Can we give heparin to a patient, especially in the setting of bleeding? And can we give antiplatelet medications to a patient, especially if there is a potential need for an external ventricular drain in a patient with a ruptured aneurysm and at risk of developing symptomatic hydrocephalus? Here is an example of a schematic drawing of a stent-assisted coiling. You can see the opening of the aneurysm is very wide, and that is the neck of the aneurysm. And so here, a small metal stent is placed across the neck to provide coverage. After that metal stent is in place, coils can be safely deployed into the aneurysm without risk of aneurysm or without risk of coils falling out of the aneurysm. Here's a patient that underwent right radial access. Here's a radial angiogram. And here is a right vertebral artery injection showing the vertebral artery here on the right, basilar artery, the posterior cerebral arteries, the superior cerebellar arteries, anterior inferior cerebellar arteries. The right vertebral artery meets the left vertebral artery here. And here you can see is a large medially oriented aneurysm affecting the V4 or intradural segment of the vertebral artery. This aneurysm is at risk of rupture and exposes the patient to stroke and death. Here you can see a stent has been placed from the vertebral artery distal to the area, the neck, and subsequently coils have been placed within the aneurysm. After placing a coil, angiography is performed to confirm appropriate position before detaching the coil. And in that fashion, additional coils are. Here you can see the stent with coils. Here you can see stent with the coils after tight pack of the aneurysm. Here's the final angiogram showing no filling within the coils or the aneurysm. The risk of rupture from this aneurysm after placement of coils and stent is extremely low. Balloon-assisted coiling can be performed when we do not want to place a stent. Some of the reasons we don't want to place stents are in patients that are not good candidates for dual antiplatelet therapy. For example, patients that have subarachnoid hemorrhage or patients that are on anticoagulation. In this scenario, we can place a microcatheter within the aneurysm, place a balloon across the neck of the aneurysm, and when we place coils, if the coils were to start to come out of the aneurysm, we can gently inflate a balloon and keep the coils centered within the aneurysm. Balloon-assisted coiling is extremely helpful in the setting of a wide-necked aneurysm in which the aneurysm is ruptured. Additionally, we can avoid use of stent. Finally, we find that the efficiency of coiling, meaning the time of the procedure and the total number of coils, is better using a balloon than not using a balloon. Another concern is when coiling aneurysms, there is a risk of aneurysmal rupture, meaning placing coils in the aneurysm may result in bleeding. To stop bleeding, having a balloon available would allow early control of the aneurysm, bleeding to be stopped, and allow for placement of additional coils. I generally treat all patients with aneurysms that are ruptured with both a balloon and coil. Here you can see an aneurysm where the opening to the aneurysm looks pretty narrow here relative to the aneurysm, but when you look at another view, the neck of the aneurysm is quite narrow. When we do 3D reconstructions, meaning create a 3D model of the aneurysm, we can get very accurate measures of the aneurysm size, the neck of the aneurysm, and in this case, this patient has another aneurysm on the opposite wall. Here you can see a microcatheter has been navigated into the aneurysm and a balloon has been navigated across the neck or the opening of the aneurysm. I have outlined these two catheters in two different colors. The coiling catheter used to deploy the coils is outlined in gray. The balloon catheter is outlined in yellow, and those two blue dots represent the markers where the balloon is going to be inflated. After inflating the balloon, we can see how the coils are forced to stay in the aneurysm rather than prolapse into the parent vessel. It allows us to get fewer coils into the aneurysm and also to pack the aneurysm tightly. Here you can see the final result. There is excellent remodeling of the coils around the parent vessel. The aneurysm is occluded with coils. There is no contrast extending into the coil mass or to the dome. This aneurysm is well treated, has low risk of recurrence, and the patient should be at extremely low risk of bleeding. I will say endovascular treatment of aneurysms generally requires surveillance. Surveillance meaning MRAs or CTAs between 2 to 5 years, depending on the treatment and at the preference of the performing physician. An additional type of aneurysm which we find very difficult to deal with are large aneurysms greater than 10 millimeters with a large neck. The reason these are difficult for us to treat is because they are large volume and they have high recurrence rates. Aneurysms greater than 10 millimeters with 4 millimeter neck or opening have recurrence rates of up to 50%. This requires large number of coils, long procedure time, as well as radiation dose to both the operator and the patient. So now we're looking at the final type of treatment, which is treatment of the neck of the aneurysm. It has been described that aneurysms are a symptom of the disease rather than the disease themselves. The disease reflects problems with the parent vessel. So instead of focusing on the aneurysm, why not focus on the neck? This approach to dealing with the neck and focusing on pathology at the neck is similar to extra-aneurysmal treatment, where a microsurgical clip is placed across the neck. Here we can see a flow diverting stent. This is one of many stents currently available. This is called a pipeline embolization device. And what it is a tightly braided stent, meaning there is a lot of metal, there's openings in the metal, and what this does is serve as a framework for endothelialization. Once these stents are placed, endothelium grows across the neck of the aneurysm, and the aneurysm will thrombose, meaning clot off, and eventually be absorbed by the patient. The success rate for these type of devices is greater than 85%, and more impressively, the risk of recurrence is 0% in these patients. This is in contradistinction to use of coils where recurrence rates may be 50%. One interesting issue is when we place these stents, the flow into perforating vessels, here you can see a pathologic specific cross-section of a vessel, and here is the device, and here is a vessel. You can see on an electron microscope that the perforating vessels stay open, whereas the areas of the blood vessel in contact with a stent endothelialize or completely heal. This is how we're able to place these stents into the blood vessels in the brain and keep normal vessels open while closing the aneurysms. Here you can see a large aneurysm affecting the right internal carotid artery. We've been able to navigate a series of wires and catheters beyond the aneurysm, and here you can see placement of two telescoping, meaning pipeline, inside of pipeline devices from the internal carotid artery supraclinoid segment into the cavernous segment. Here's a magnified view showing this device. It's S-shaped. You can see it's not well opposed to the wall. Over time, however, the aneurysm will thrombose, the stent will endothelialize, and the vessel will completely remodel. This is the initial treatment, and this is a 6-month follow-up. If I was shown both of these images, it would be hard for me to tell that they were the same patient. There has been beautiful remodeling of the vessel, and the likelihood of this aneurysm recurring should be close to 0. This has been a game-changing technology for us, and focusing on aneurysm neck treatment. We do generally do dual antiplatelet between 6 months and 18 months, and then aspirin monotherapy for life. Potentially, we would reduce the aspirin to 81 milligrams at 1 year, and in some patients, stop aspirin completely at 5 to 10 years. Some of the future issues and problems to solve are wide-necked aneurysms in the setting of subarachnoid hemorrhage when we would like to avoid using a stent. Bifurcation aneurysms, meaning aneurysms that occur at branch points, also need to have better endovascular solutions. Additionally, the cost of the materials and cost of procedures is quite high. So increased efficiency with radiation dose, improved safety, and decreasing costs are all goals that we strive to achieve. As I had said, intraaneurysmal treatment, meaning coils, and now improved, newer devices, intrasaccular devices with improved coils have been looked at. In terms of neck treatment with flow diverting, we now have second-generation devices, Fred and Sure-Pass. This is another approach to endosaccular treatment in patients with wide necks and wide-necked aneurysms and bifurcation. This is called a web. It is a woven endobridge, and this device is very much like a stent, like a flow diverting stent, except made into a ball. Here you would insert a microcatheter, you would deploy this ball, which has been measured to fit the aneurysm, and leave the ball in place when removing the microcatheter. 2 companies are producing these devices. Webb is made by Microvention. Luna is made, is made by Medtronic. We currently use the Webb device at Christiana on a routine basis. Here you can see this woven endobridge is actually a ball of metal. It's deployed into the aneurysm. It extends from the neck to the dome, and we are having striking results. This is a patient presenting with a ruptured basilar apex aneurysm. These aneurysms are generally very challenging to treat surgically. They are generally treated with a combination of coils, balloons, and stents. These procedures with coils, balloons, and stents can take several hours, require placement of 30 or 40 coils, and placement of stents, and be quite time-consuming and expensive. With a new woven endobridge, we were able to navigate a small microcatheter into the aneurysm after carefully measuring the aneurysm and the device, deploy the device, and immediately get occlusion of the aneurysm. This patient's procedure can take less than an hour. Additionally, there is no need for antiplatelet, the procedure is quicker, and there is immediate occlusion of the aneurysm. This is a game-changing technology and allows us to treat aneurysms that previously were difficult to treat endovascularly, such as basilar apex aneurysms, MCA bifurcation aneurysms, and anterior communicating artery aneurysms. In summary, endovascular options continue to evolve. The safety continues to improve. The durability of the treatments continues to improve. And I think patients in Delaware suffering with aneurysms have a bright future. There are many options available, and the safety profile, the speed, efficiency, and durability are significantly better. I'd like to thank you in advance for your time. Thank you for the opportunity to speak to you today. My email is listed below. Thank you. I will be available for questions later in the session.
I don't see any questions right now from the audience, Sadako. Maybe I can ask you a question peripherally related to your talk that we run into almost on a daily basis. Yeah, and I'm sure you do as well. The incidental aneurysm, if a patient has a TIA or maybe a headache or something, he gets an MRA and has a small aneurysm, 2 or 3 millimeter aneurysm, with rounded dome, not a lobulated. Is it recommended to follow those folks? And if so, how often and how long should you get a follow-up for?
Yeah, Lee, thanks. Can you hear me okay?
I can.
Yeah, thanks so much for the question. Thanks again for the opportunity to speak today. Yeah, that is an increasingly common problem because of increased imaging. And so what I would say is any aneurysm that's 4 millimeters and less should have at least one follow-up image. So an MRA at 1 year, and then a follow-up MRA at 2 years until the patient is probably around 80. And if the aneurysm is 4 or 5 millimeters in high-risk patients, such as those we mentioned, female, hypertension, multiple aneurysms, anxiety regarding the diagnosis, we're happy to, you can refer them to somebody who, treats aneurysms. We're happy to see them in our group, but if you have other people, that's fine. Once you get to about 5 millimeters, high-risk patients, we consider treatment if it's technically feasible and if the technical risk is lower than the risk of the aneurysm. So in general, aneurysm rupture rates probably around 1% per year. So if the patient has a life expectancy of less than 5 years, generally we're not going to treat small aneurysms. Once you get to about 6 to 7 millimeters, many of those patients may be candidates. Does that answer your question, Lee?
Yeah, that was a great answer. Thanks. That is really helpful to have that guidance, and thank you for the excellent talk, Sadako. We are really very fortunate to have someone of your caliber and your colleagues' caliber in our backyard. So it's really a great thing for the people of Delaware.
Yeah, well, I'm very lucky to be part of the community. I think the community of neurosciences in the state is great, and in the 11 years I've been around has significantly increased in terms of number and expertise and capacity. So I'm very, very lucky to be working with such a great team.
Yeah, well, we're glad you're here. Thanks for everything you do for our patients, and thanks for another excellent talk, Sadako.
Thank you so much.
I don't see any other questions. We'll probably move on to our next speaker. My co-host, Mania McMullen, was going to introduce Dr. Devereaux. Mania, are you on the talk? I think, unfortunately, Mania's had some technical problems, so I will plow ahead and. Mania, can you hear me?
I can hear you.
Okay, I'll let you take it from here. Mania is the stroke coordinator for St. Francis Hospital.
Yes, give me 1 second while I fix my screen here. If you want to introduce Dr. Devereaux, you can go right ahead, Lee.
Okay, well, maybe we could trade off. I'll
Okay.
let you do the next one. So our next speaker, we're very fortunate to have is Dr. Devereaux also from Christiana Care. And Dr. Devereaux is a expert in neuropsychology and psychology. She completed her internship at Rush Presbyterian St. Luke's Medical Center, and she earned her doctorate at Rosalind Franklin University of Medicine and Science. She then completed a fellowship at the Rehabilitation Institute of Chicago. And Dr. Devereaux specializes in psychology, rehabilitation psychology, and clinical psychology. And she's going to introduce a very important topic for us, which is the psychological effects of stroke and post-stroke PTSD. So thank you very much, Dr. Devereaux, for speaking with us this morning.
Thank you, Dr. Dresser and the committee. I'm going to share my screen. Let me see if I can start. I'm probably pressing the wrong button here, so let me try that again. Okay. All right. Well, let me do this. So trying to minimize the speaker gallery here. Just do that. Okay. I have so I'm Nancy Devereaux, working at Christiana, seeing inpatients and outpatients who have rehabilitation issues, particularly stroke is one of them. And I have no disclosures to declare. The basic objectives are just to briefly describe a number of psychological outcomes that can emerge from stroke, and at least 2 to 3 depending on our time, and risk factors and potential consequences of post-stroke depression, and then some of the treatments and the literature issues. So some numbers. As we all know, we work with this group that globally and in the United States, stroke is an important medical condition, and it causes a lot of issues for many people. It's important for us to take care of. And mental health is another set of disorders that are quite challenging. And the intersection of that is kind of where I work. And anxiety disorders are actually the most common mental illness in the United States in persons who don't have stroke. Major depression. The thing is, if you look at depression, there's different subtypes. So when you collectively put them together, it may be a larger group, but close to 8% in the United States. People with depression have a 40% higher risk of developing cardiovascular and metabolic diseases. And psychological effects of stroke, whether depression or otherwise, are associated with poor outcomes and a lower quality of life, earlier mortality, cognitive issues, caregiver burden. Some of the psychological effects of stroke include depression, anxiety, post-traumatic stress disorder. We see apathy and irritability on our units quite a bit. I'm gonna keep aware of time. There are some other interesting syndromes that occur that can be considered neuropsychological in nature. I won't get to those today, but certainly those of you who work in the acute and rehab will see a lot of this. And briefly, anxiety after stroke. Even though the general population is estimated to have less than 20% at any given time, after stroke, you could have up to 25% incidence of anxiety. And it's associated, it is associated with post-stroke depression. And when the two are co-occurring, the anxiety issue lasts longer and is harder to treat. And some subtypes of anxiety disorder, some differentials to consider. But regarding treatment, relaxation training can be helpful. And some of the studies indicated that paroxetine or buspirone could be helpful. Comment on paroxetine, that is associated with quite a difficult discontinuation syndrome. And fluoxetine probably has the lowest of the SSRIs, the lowest discontinuation syndrome. Buspirone, interesting that that was studied because we are concerned about our patients taking benzodiazepines. Excuse me. And some studies indicated that when they combined paroxetine with psychotherapy, there was some benefit. Focusing a little bit on post-traumatic stress disorder, one reason is that it looks like across the nation and certainly at Christiana Care, trauma-informed medicine is really being focused on and expanded, a lot of training going on. And some people might think, well, PTSD, you think of specific, incidents that we hear about, we know about the combat stress and rape survivors and so forth. You don't always think about stroke as being associated with PTSD. So the prevalence rates, prevalence estimates can vary for PTSD after stroke. And that is one of the issues, is that when you look at the literature, there's quite a variety of findings and quite a variety of studies, whether they're prospective, retrospective, and limited. But it looks like there could be up to 1 in 4 stroke survivors who have symptoms that could be considered PTSD within the first year. And that includes, the criteria include having been exposed to an actual or threatened death or injury or violence, which stroke is included in that. Intrusive thoughts, memories, avoidance of stimuli associated with that event. There's negative alterations in cognition or mood, marked alterations in arousal reactivity, and the duration is over 1 month. So a lot of times in our hospital, in acute care and even on rehab, if we see someone with some of these symptoms, we have to consider the diagnosis of acute stress reaction or an adjustment disorder with anxiety, possibly due to, if it's less than 1 month duration, at least according to, if we're going to use the Diagnostic and Statistical Manual, APA, that was the DSM-5's 2013. I just wanted to comment that PTSD had been considered an anxiety disorder, and it was finally removed from that category for those who are interested in the classification, and it has been placed in a category of stressor and trauma-induced disorders, partly because the emotional reaction can be different from anxiety. And so after stroke, post-stroke PTSD, it's not clear from the studies, but there may be an association with a higher frequency of right cerebral and brainstem lesions. Some of the MRI, fMRI, and MRI studies indicated volume reduction in the ventromedial prefrontal cortex and the hippocampus. And again, there's problems with the literature, but there's a trend. These folks have a higher degree of disability. And it's interesting that some of the studies showed that the ER experience contributes to the development of PTSD. So several actually talked about crowding in the ER, which to me, that might be more of a perception than an actual way to measure that. So there's interesting studies there. And PTSD appears to be associated with non-adherence to medications, both before and after. So working on helping patients to really tune into their regimen and to buy in and to have some motivation and support for following through. So there's other variables that may be associated. It's not really clear, although again, trending. PTSD after stroke may occur more in women and at younger ages. And there are limited studies in the area of treatment for post-stroke PTSD. In a study by Gal and others, citalopram and CBT were associated with good responses. And 9 months later, when they were continuing with the study, CBT alone, which is cognitive behavioral therapy, appeared to be more effective but there's just not enough studies out there. Now, there are very specialized, kind of requiring high training, intensive training, evidence-based treatments for PTSD in patients who don't have neurological disorders, who have PTSD. So that includes, cognitive processing therapy, EMDR, some of these you're familiar with, and SSRIs have also been looked at in this population. And sertraline, paroxetine have shown good results. Again, paroxetine, you want to be careful with that discontinuation syndrome, and fluoxetine and venlafaxine also, but not well studied with the stroke population. The most common disorder, psychological disorder after stroke, is depression. It's and it may even be more common than the literature shows. It occurs more common in the stroke population than in the general population, and could be up to 1 out of 3 patients who develop post-stroke depression within 5 years, most during the first year. The reason I say it may be more common is because of the exclusion. So many studies looking at this did not include patients who have had a history of depression or mental health disorder before, who've had a history of stroke before, patients with aphasia, patients with hemorrhagic lesions. These people have depression too. So it'll be helpful to see what they can do about that to get a better fix on what is really going on and how many people are affected who have had some type of stroke. So when we're talking about depression, usually we're considering major depressive disorder, although there are other types. And it includes at least a persistently low or depressed mood, and or anhedonia, which is the decreased interest in pleasurable activities. The problem with some of the depression criteria is that there are a number of features that can be a confound because the stroke effects themselves, or the effects of medications, particularly medications that are new to the patient, may contribute to more of the physiological symptoms such as appetite changes, the psychomotor changes, sleep disturbances. I'm not going to go into, there's other exclusion or other types of depression. So commonly used instruments across the studies include this list here. What I want to highlight is that the Patient Health Questionnaire -9 is probably the most often used. We certainly use it in Christiana. We use the PHQ-2. I think on the acute care, I work in the rehab unit, so on the acute care units, they can comment better than me, but I think they tend to use the PHQ-2, which has these questions. And unfortunately, I can't remember if it's a score of 2 or above what the cutoff is, where that will trigger, usually will trigger a consultation request to psychology or psychiatry, the liaison. And I just wanted to make a comment. When I use the PHQ-9, I actually use it in sort of as an adjunct to an interview, the interviewing tool in part. So to kind of try to establish rapport instead of just firing questions at people. And I always ask about feelings of hopelessness separately from the sad mood, because people can answer differently about depressed mood, sad mood. It can mean different things, but hopelessness is usually more serious and can be more persistent. And then suicide screening, I think that's pretty standard that we're carrying out suicide screening, either the Columbia or an item on the PHQ-9 and similar. And I always ask about that too. So what are risk factors for post-stroke depression? Again, the literature is pretty inconsistent. There are many studies, a lot of them even with meta-analyses, and it's not always consistent, but it does seem to be a trend towards stroke severity, then possible genetic predisposition or family history and or history of the patient's own psychiatric disorder. Problem with that is those patients are often excluded. No surprises there from what we talked about earlier. There's also a lot of controversy over the years about the lesion location. I know that Robert Robinson and his colleagues for many years were talking about the left frontal, left basal ganglia as the important locus for post-stroke depression, and left frontal functioning was important. And like we have studies of like meditation and depression without stroke. But there's a lot that differs out there. So Robinson and his colleagues are now saying, well, it looks like the left frontal or VG lesions are important within the first 2 months of stroke. But then afterwards, it's kind of like, it's up for grabs. So I'm not really sure what that means, but I know that excluding aphasic patients from many of the studies, I know there may be some questions with validity and reliability sometimes of assessing these patients, depending on the degree and type of aphasia. But there's, I didn't put that on this slide here, but there are some studies that show that patients with, the limited studies, of course, show that patients with aphasia do tend to have possible higher rates of post-stroke depression. And also a risk factor has been found to be, not surprising, probably is the cognitive dysfunction, ADL impairments, and stroke severity. And then low social support, which makes sense as well. And, if a patient has had this important life change and they're depressed, and who's there to help them through it. So I'm not going to get into the pathophysiology. That's not really my wheelhouse, but it's very interesting. There's a lot of theories out there about, networks and the biomarkers, BDNF, the pro-inflammatory cytokines. There's a lot going on with that. It's pretty interesting. And there's some, fun little pictures to show some of that. This is, for instance, one group proposed that there are networks, this is for patients with depression, not necessarily stroke, post-stroke, and any disruption to a region or to connections. Always the amygdala, the cingulate cortex figures in, the prefrontal cortex, striatum. And then another kind of cool little graphic by another group, very complicated, but basically what I take from it is that, well, there's, what are the precursors? What are the the biopsychosocial components, as well as the actual neurochemistry and lesion location and neurotransmission, and how that may affect post-stroke depression. Again, it's not confirmed, it's not real well kind of cemented in the literature as to what is really going on, but interesting theories and room for more studies. So what is the best treatment? So again, there's kind of confused literature at times. What I do know and what I was reading is that there are some excellent treatments for patients with depression, but not all of those were fully researched as yet, at least in a reliable and valid way for this post-stroke depression population. What does seem to emerge so far is at least three sets of treatments that are promising. The pharmacy medications, SSRIs, SNRIs, a lot of the studies are older, so TCAs, you don't really see too many people using the tricyclics anymore, except maybe for sleep or pain, some measure of that. There's also cognitive behavioral therapy, and there's subtypes of that, so it's not always well defined what exactly they did. But personally, I feel that when it can be tailored to the particular issues of the patient, I mean, it really has to be to the problems and the negative thoughts that they may have about what is going on with them and their fears about the future, and how that interacts with, you know, the effects of those maladaptive thoughts on their emotions and behaviors. And then there's studies with non-invasive brain stimulation that are emerging. They tend to have a small n, but they're interesting too. Repetitive transmagnetic stimulation, transcranial direct current stimulation. Supposedly it's, I don't know, it's some kind of thing they put on and they don't feel it, but the results seem to be, we'll call them promising. There were some issues for a while, just real briefly. Fluoxetine has had been studied both for motor recovery and depression, either prevention or treatment post-stroke. And there's some studies that are questioning that, but it seems to be hampered by problems with the assessment and measurement of depression. So that might still be a mixed kind of set of results there that need to be sorted out or studied further. How are we doing? Not real well on time, right? Some other promising treatment studies, you know, varied studies that don't have necessarily large ends, or they're kind of correlated with some other kinds of interventions. So it's hard to tease out what exactly is responsible for what. But mind-body interventions, yoga and Tai Chi. Interestingly, some of the studies from China show really good responses, but it also has been commented that we need to take cultural factors into account sometimes with treatments, because, for instance, in China, there's more of an acceptance and understanding of an intervention such as Tai Chi, and perhaps it's possible that this population may react more or respond more favorably, and it's not well studied yet in some of the Western populations, but again, sounds promising. Exercise, we know, has been known lately in research studies as being beneficial for both anxiety and depression. Motivational interviewing should be able to help, because some of the problem with treatments is follow through, especially when a patient is discharged home or does not have a lot of support for following through on some lifestyle interventions and even cognitive reframing that may be helpful to them. And then some of the studies, the authors wanted to caution that there can still be association of side effects with the SSRIs and related drugs, to be careful with that. I wanted to just briefly cover just some cases. One, just to show in my own work how psychotherapy can be helpful. This was a patient with right hemisphere stroke, and initially PHQ-2 score 0. And I'm not always surprised. Sometimes people, they're still sorting it out. What has happened to me? What's going on? Sinking in. There's different, almost like different stages of awareness and understanding of the implications. So sometimes it makes sense to me that depression or depressive feelings can develop over time. So this patient was started on fluoxetine and had some difficulty sometimes coping. Part of it was during COVID, not being able to have visitors, missing his family. And went home. Symptoms were under decent control with the fluoxetine and feeling that he made some gains. And depression was under decent control, had things to look forward to, back with family. And he participated in outpatient rehabilitation therapies, made some gains to a point in terms of left upper extremity, and was starting to experience depression and irritability as I don't know if it was correlated with the increased awareness of his deficits, but day to day seeing how things were going, and probably a sense of plateauing and not tolerating frustrating situations well. So, and I actually saw the patient for a few sessions about 8 months after discharge, and it was nice. It worked well because I did a variety of cognitive behaviorally oriented and problem solving interventions to kind of help normalize, help put things in perspective, to understand how the deficits, the brain lesion and interaction with the deficits, and kind of like, yeah, well, this is why you're having dressing apraxia, these kinds of things. And reappraising, helping him look at the messages he said to himself, how to restructure some of those, practical solutions, setting up his day differently so he wasn't as frustrated, and working on some communication of his needs to the family, feeling like they were like honing in and hovering, and sometimes he didn't realize how much help he needed for safety reasons. So we kind of worked around that, talked to his wife a little bit in the session, and there were some improvements. So we thought, okay, I think I know what to do. Another patient, just briefly, just wanted to say that after several trials, he was a hemorrhagic stroke patient. And interestingly, he worked pretty well with psychotherapy, although some limitations due to memory problems and vision deficits. He tried 4 or 5 medications, and for some reason, Ptsd was like the magic one. I don't know very many patients who take that, but I was amazed at the response. I'm not going to say it was perfect, but it was really impressive how, even though he was working on behavioral activation, now it was easier and his mood was much better. So real quickly, I know I need to stop, but there's a lot of limitations in the studies, a lot of the usual things we know with clinical research. But it is an important area. It needs to be studied further, and we need to attend to our patients. Under assessment and under treatment has been actually admitted by just about every author of the research. So we need to study these treatments better. I think I just wanted to comment on some of the things that our patients are concerned about. Some of you working with them will notice that you've heard these too, or you may have others that are of concern, not wanting to be a burden. Will I work? It's hard not being able to do what I used to do. So there's these issues of guilt, self-worth, loss of identity, mourning the loss. I think that when we support our patients, it doesn't matter whether you're a psychologist or not, just listening, helping them with a forward focus, providing steps for positive motivation, family involvement when they're supportive, and stroke support groups, family support, all of that, I think, goes a long way. Future research basically is just if we can do the randomized controlled trials and continue to work in this area and include some of the groups that have been excluded. So, so all of us can work together to help our patients do better at every level of care, whether it's inpatient, outpatient, rehab, in the community. So thank you. And I'm going to see if anybody has a few questions.
So I think, Dr. Devereux, there's one question from a lady who works in home health, and she asks about homebound populations. Are there telehealth services available for them to receive psychological or neuropsychological services?
Sure. A lot of times in home health, they're linked with a hospital, and many times the hospital that you're linked with may have outpatient psychiatric or mental health services. There's a lot of practitioners in the area, although I think the need is for someone who understands the neuro aspects of the issue. I know, certainly we at Christiana can see patients for an outpatient service, but and there is more telehealth available, I think, across, at least in Delaware. I can speak for Delaware, and I know some of you treat patients in Pennsylvania and so forth. So I'm not really sure how the different home health departments, how they reach out to these services, but I'm going to assume that at least most hospitals will have a department of mental health or behavioral health and be able to interact with, interface with home health to provide some support. I know there are psychiatric social workers that can also be part of many home health organizations, and that is a start too. Does that make sense?
Sure, yeah, thanks. So, Sadako, did you have a question?
Yes, thank you, Dr. Devereaux. That's an excellent presentation. I had a question. I'm hearing more and more about loneliness. And so my two-part question is, do you screen for loneliness, number one, and then number two, are there any interventions that can be recommended or instituted?
Well, loneliness is really a big deal. I mean, I think across any medical and even non-medical diagnoses. So, and that was one of the pieces of information with that I had on one of the slides that has to do with, you know, a lack of or limited social support. So you can't just invent friends, I realize. And I do encourage patients to try the community support groups. I know Kate runs one, you know, we have one. I'm not sure how the general population gets that together. I know that the statewide stroke committee is working on these kinds of things too, to make resources more available to everyone. So I would want to have the patients identify the support groups at least, and interest, some kind of interest, even online. Even if the person is not able to get out, and certainly with COVID, I would suggest sometimes having an interest is an inroad to being less lonely. Like whether it's, you know, I love to do photography, you know, and there's meetup groups and so forth that are online. There's maybe other suggestions from other people as well, but I do think that's a big problem in America. Thanks.
Thank you for the excellent talk, Dr. Devereaux. That was great, and that's such an important topic. So I'm going to ask Mania to introduce our next speaker.
Thanks.
Good morning. My name is Mania. I'm the stroke coordinator at St. Francis in Wilmington. Our next speaker is Dr. Yadananda Pudi, the board certified in neurology and vascular neurology, also known as stroke neurology and internal medicine. He previously helped run the stroke clinic in neurointensive care at Einstein Healthcare Network in Philadelphia. Dr. Yadananda Pudi completed his medical degree at Andhra Medical College in India and his internal medicine residency at Bronx Lebanon Hospital Center. He completed his neurology residency at Einstein Healthcare Network, where he was the chief resident. He also received specialized fellowship training in vascular neurology at Thomas Jefferson University Hospital. Dr. Yadananda Pudi is a board certified hypertension specialist with the American Society of Hypertension. And he is post-call, but will be available for questions at the end of the conference, and his talk is a video.
Thank you for having me today afternoon. I would like to thank the organizers of the Delaware Stroke Initiative for arranging this lecture series. And today I'll be talking about one of the important updates in stroke, that is Tenecteplase versus TPA in stroke. Because we'll be discussing many of the studies done on Tenecteplase, I just want to go over some terminology. We're going to be looking at things like the NIH stroke scale, which is 11-part deficit scale for strokes, where lower numbers predict better outcomes. We're going to be looking at what is called the modified Rankin score, which is a score from 0 to 6. And the higher your score, the more your disability. So 0 to 1 is a very good outcome. That's what we're looking for. DVTs, endovascular therapy, most of the trials, and NIH of more than 6 with a small core, a large penumbra, and a large vessel occlusion would go for thrombectomy. LVO means large vessel occlusions. When we say that, we are usually referring to the clot in the middle cerebral artery, basilar, or the internal carotid. And just in the interest of space, we will be using the short forms Tnk for Tenecteplase and TPA for alteplase. But I highly recommend not using them in your notes and in day-to-day practice. We'll talk a little bit about the pharmacology of Tenecteplase. We'll talk about the past trials that have been done and what the future trials are planned. So why Tenecteplase? So when you compare Tenecteplase to alteplase, you see a few significant differences. Alteplase has a very short half-life, only 4 minutes. So it cannot be given as a bolus. It has to be given as a continuous infusion for 1 hour. This can lead to a lot of logistical workflow issues, such as delay in transfer of patients, the need to go back in and see the patients more frequently, especially in times of COVID. Whereas Tenecteplase has a half-life of 20 minutes, which means that it can be given as a 5-second bolus, which makes it much faster. Also, it has some pharmacological properties that make it more favorable. It has 14-fold greater fibrin specificity. What does that mean? That means it only activates in the part of the body where there's a clot and not everywhere else, such as the gastrointestinal tract or other places where you can put the patient at risk for bleeding. And as soon as somebody gets alteplase or Tenecteplase, the body starts releasing what is called plasminogen activator inhibitor, which tries to break down the alteplase and Tenecteplase. However, Tenecteplase is 80-fold more resistant to PAI than alteplase, so it's less likely to be deactivated, which means it'll last longer. Tenecteplase, although is just making its way into stroke, it's been around for a long time. It's been approved for acute myocardial infarction for a while by the FDA. Now, one thing to know is you won't see the trials that I'm going to present. Most of them are done in Europe, Australia, and Asia. You're not going to see a lot of US trials because Genentech is the company that makes both alteplase and Tenecteplase, and they really don't have the motivation to get FDA approval for a medication that is less expensive. Tenecteplase is less expensive when there is already approval for alteplase in stroke. So the first trial that was done was to try and find the proper dose for stroke. So in this study done by Haley et al. In the US, they had 88 patients and they were recruiting into multiple different dosages, 0.1 milligram per kilogram, 0.2, 0.4. They were even planning to include 0.5 and 0.6, but they saw higher bleeding rates, so they stopped recruiting at those doses. The trial, this was not a randomized study, but it did show, compared to historical TPA controls, there was about the same outcomes as far as benefit was concerned for Tenecteplase. And it looked like the 0.1, 0.2, and 0.4 doses were all relatively safe. So in moving forward in all the trials, you're going to see these 3 dosages, but we don't use the 0.5 or 0.6 for stroke. So the second part was the Tnk S2b trial, which was also done in the US. In this, they did a randomized double-blind trial where they took the 3 dosages which were found to be beneficial with the lowest risk of bleeding, and they were compared to the standard, which was alteplase, for patients coming in with acute strokes within 3 hours. This trial was terminated because of slow recruitment. However, there was no significant difference in outcomes. The only significant difference that was seen was at the 0.4 milligram dose, which showed a signal towards higher bleeding risk. So from this trial, it became more clear that maybe even 0.4 was too high bleeding risk, and maybe 0.1 or 0.2 are the doses that should be considered going forward. Then came the only phase 3 trial that we're going to talk about regarding Tenecteplase. The rest of the trials are all phase 2. This was a randomized open label blinded study. It was designed to be a superiority trial, and it was done in Norway. And the design was acute strokes coming in within 4.5 hours. They did allow wake-up strokes, and this is something new that is becoming more common in the world of acute stroke care, is treating wake-up strokes with thrombolytics. But there weren't a lot of patients, so you really can't comment on Tenecteplase in wake-up stroke. They were randomly assigned to 0.4. Even though the previous trial showed a signal that 0.4 had higher bleeding risk, the authors weren't convinced because the numbers weren't big. So they decided to look at 0.4, and they compared them to usual GPA. This trial had a few criticisms. You will see that stroke mimics were almost 20%, which does muddy the results. 80% were mild strokes, which means an NIH of less than 4. And we know that mild strokes, even if they don't get TPA, there is a good chance they'll improve by themselves. So again, this affects the outcomes. And there was a lot of protocol violations, and they did not use any advanced imaging to select the people with clots. And the trial did not show any difference between number of patients that were independent, which is modified Rankin of 0 to 1, or hemorrhage risk, which was around 9% in both. At the same time, what was being noticed was that large vessel occlusions were becoming more and more. There was a search for new treatments in large vessel occlusion. So the group in Australia decided that instead of having all comers with stroke, and which has the chance of having stroke mimics and everything, they only wanted to have large vessel occlusions. So the group from Australia, by Parsons et al., they looked at Tenecteplase in people with large vessel occlusions, middle cerebral, basilar, internal carotid occlusions. This was before endovascular therapy was standard of care. This was an open label trial. They compared 0.1 Tenecteplase and to CPA, and within 3 to 6 hours of stroke. They did use advanced imaging. So these were patients with tiny cores, big penumbras, who had a favorable profile. And what they saw was a high rate of reperfusion with Tenecteplase. This is the first time you're seeing that Tenecteplase is better than alteplase in large vessel occlusions. And then there was 0 as hemorrhages in the Tenecteplase and 4 in the alteplase, which did not reach statistical significance. The next trial done by the same group was comparing 0.1 and 0.25 of Tenecteplase in less than 6 hours after onset of 16 ischemic stroke compared to alteplase standard dose. Again, they used eligibility criteria was a large vessel occlusion with a favorable penumbra profile. Again, you see a strong signal for Tenecteplase opening large vessel occlusions. So by the time these trials are coming around, what is becoming clear is 2 things. The dose of Tenecteplase, and which was 0.1 or 0.25, 0.25 being a higher, more effective dose in this trial. And 0.4 has an effective dose, but a higher risk of bleeding. And then the population that seemed to benefit, which was large vessel occlusions. So large vessel occlusion and a dose of 0.25. Then came the Attest Trial. One of the criticism for the previous 2 trials was they were only selecting patients with advanced imaging, CT perfusion. In many centers, CT perfusion is not available, let alone CT angiograms. So you're giving GPA or Tenecteplase if you decide to go with Tenecteplase right after a CT scan. So that way, those 2 trials, although they showed benefit, that's not, their design wasn't exactly pragmatic in line with the workflow in most US hospitals. Attest, on the other hand, was kind of similar to that. So Attest was done in Scotland, and they again looked at large vessel occlusions, but they did not use advanced imaging to decide who gets Tenecteplase and who doesn't. They did it just so that they would have the data. Again, in this trial, they looked at the 0.25 dose, which has shown the best safety and the benefit signal against a standard dose of alteplase. And what they saw was there was higher recanalization rates with both alteplase and Tenecteplase. They did not see any difference. Now, part of the reason for this might have been that the Tenecteplase group had when you look at the CT perfusions in the study, they were a sicker group. They had bigger cores and larger strokes that were already completed. And we think that was probably why this study did not show a big difference between Tenecteplase and alteplase. Hemorrhagic events were lower with Tenecteplase. Then came the Stent trial. This is to date the biggest trial for Tenecteplase. And what you will see is these are all large vessel occlusion patients, and they were randomized to either Tenecteplase 0.25 or GPA 0.9. And the primary outcome was reperfusion rate. Now you might say, well, most stroke trials, you look at modified Rankin, you look at NIH stroke scale. Why was it reperfusion? Because by the time this trial was done, endovascular therapy had also become standard of care. In all the previous trials, the patients were not going for endovascular therapy. That was pre-2015. So instead of trying, because endovascular therapy is going to affect outcomes, you can't just look at outcomes. What they decided to look at was people who reperfused without going for endovascular therapy. This is very, very important. So what you see in this is reperfusion rates without going for a thrombectomy, with Tenecteplase was around 22% and GPA was 10%. So number needed to treat was 9, which is pretty good. So if you treat 9 people with Tenecteplase who have large vessel occlusions, one of them will not need to go to thrombectomy suite because the clot has already opened up. So you're saving a procedure. And also, if you think about hospitals that drip and ship patients, when you give Tenecteplase and you send them to another center, it takes a long time to get to a thrombectomy suite. If some of these patients are going to have their clot opened up by the time they reach thrombectomy, that's a huge benefit for these patients. Again, advanced imaging was used, but after the first 80 patients were enrolled, they stopped using advanced imaging to decide who gets Tenecteplase and who doesn't. And one thing they did notice was there was no, the patients who got Tenecteplase did not, there was no like time savings in the Tenecteplase and Alteplase group. This is just a Grotta plot showing that the Tenecteplase and Alteplase group. You can see more patients had higher modified Rankins of 0, better modified Rankin of 0 to 1 compared to the Alteplase group. You will also see that at 24 and 72 hours, the patients who got Tenecteplase had lower NIH stroke scales because of early reperfusion. Because the 0.1 dose was still being looked at, the second part of the study compared the, the 0.4 dose was still being looked at. The second part of the study compared the 0.4 and the 0.25 for large vessel occlusions. And they clearly showed that 0.4 doesn't seem to make any extra benefit for large vessel occlusion strokes. So just looking at the trial so far, what we are seeing is a signal for 0.25 milligrams per kilogram of Tenecteplase. And the population that seemed to benefit the most is large vessel occlusion strokes. Another group that is of interest is basilar artery occlusions. These are not common strokes, but they're pretty devastating strokes. So the group from Australia decided to go back and look at all their registries and look at the data on basilar artery occlusions within 4.5 hours of onset. And reperfusion rates again in Tenecteplase was 26% compared to only 7% in Alteplase. And thrombolysis to arterial puncture times were shorter in the Tenecteplase patients versus the Alteplase, but this might be because many of the Alteplase patients were drip and ship, so it took longer to get them to the thrombectomy suite. But definitely a benefit of recanalizing basilar artery occlusions. So the group from LA decided to look at all the trials together and do a meta-analysis to see between Tenecteplase and Alteplase, what can we learn? What they did show is that recanalization of large vessel occlusions is like 3-fold better with Tenecteplase compared to Alteplase. What is more of an equipoise is the outcomes, just because endovascular therapy is also standard of care, and there weren't enough strokes without large vessel occlusions, like lacunar strokes. And also another thing that was neutral was the mortality and the intracranial hemorrhage rates, which were similar in most trials between Tenecteplase and Alteplase. And these are just 2 slides for your reference. which show all the other studies, including case series, non-randomized studies, looking at data on Tenecteplase. Now, this brings me to the future trials. If you're an institution that is considering switching to Tenecteplase because of the things we talked about, ease of administration, higher rates of recanalization, one thing to consider is participating in a trial. Because what we still don't know about Tenecteplase is whether it works well for wake-up strokes, which is becoming more and more common across many institutions to give alteplase for wake-up strokes based on MRI findings. And if it works for things like central retinal artery occlusions, which we also, the American Heart Association recently came out with a statement saying alteplase is of benefit in central retinal artery occlusions within 4.5 hours. And also for other things like, non-large vessel occlusions like subcortical infarcts. Does Tenecteplase work? If so, at what dose? So one thing to consider is participating in these trials that are ongoing and should finish in the next 1 to 2 years. So what do we know? When it comes to large vessel occlusions, Tenecteplase is clearly better at recanalizing, and it's even before people get thrombectomy. So that's an advantage, especially if you transfer patients. And the dose that showed the benefit was 0.25, 0.4 was compared in Extend trial, and it did not show any additional benefit. What about non-large vessel occlusion severe strokes? Coronary radiator stroke or a thalamic stroke, that can be pretty devastating, but at the same time, we don't have enough data to say whether Tenecteplase is equivalent or better than alteplase. What about minor strokes with an NIH less than 4? Again, the patients that were in the Attest trial, which had the minor strokes, both Tenecteplase and GPA were equivalent, and the dose that was studied was the 0.4 milligram per kilogram. Wake-up strokes, central retinal artery occlusions, like we talked about, there just isn't enough data. So after the trials for Tenecteplase came out, there were some changes in the American Heart Association to reflect in the guidelines to reflect this. So in 2019 guidelines, if you look at them, you'll see 2 instances where they mention Tenecteplase. One is, it would be reasonable to give Tenecteplase, the 0.25 milligram dose, over alteplase in patients with who are about to undergo mechanical thrombectomy. So large vessel occlusions, you can give 0.25. And then they mention the 0.4 dose, which they say is non-inferior to alteplase, and it can be considered in patients without large vessel occlusions who are having a stroke. Now, if you are an institution that wants to adopt Tenecteplase, if you follow the guidelines to the letter, that's going to be a problem, because you'll have to have 2 different doses. And you have to wait for imaging, which will affect your door to needle times. Most of us in the stroke world, we give alteplase or Tenecteplase as soon as the CT is done. So this presents a problem, and we are still waiting for more data to clarify if 0.25 would work for non-large vessel occlusion strokes or not. The FDA has not approved Tenecteplase, but if you think about it, FDA never approved the alteplase after 3 hours. And it's backed by AHA, and we still use it, and we know there is benefit. So the FDA backing should not be the only reason not to adapt. And if you see in a recent NIH stroke trial, the FDA agreed to appending the trial to include Tenecteplase, but that doesn't mean they've given their stamp of approval for acute stroke and Tenecteplase. Just to do some cases to get some sense of the data. This is a 67-year-old with hypertension, diabetes, hyperlipidemia, last seen 2 hours ago. So a thrombolytic candidate potentially. Left hemiparesis, slurred speech, NIH of 20, and you see the blood pressure and the sugar. Now the CT angio shows a right M1 cutoff. Which of the following thrombolytics is most effective based on the current evidence? Give a few seconds just so that we can think about what we talked about. So from the data thus far, 0.25 milligrams per kilogram Tenecteplase has more recanalization rates with large vessel occlusions, and sometimes even avoids the need for a thrombectomy, which helps some patients, which is great. Case 2 is a 77-year-old with right hemiparesis and an IH of 8. You see the blood pressure, sugar, CT angio doesn't show a large vessel occlusion. So this is somebody with no large vessel occlusion having a stroke. Which of the following thrombolytics is most effective based on current evidence? Again, I'll give you a few seconds to think about this. So the Attest trial didn't have enough patients with non-large vessel, and the meta-analysis wasn't clear if you're not a large vessel occlusion, what happens, whether it's Tenecteplase or alteplase. So for now, the current evidence is that alteplase shows the most benefit. So some take-home points. Tenecteplase, as we have seen, is pharmacologically more effective, lasts longer, can be given as a 5-second bolus, and it is less expensive. There is 2 facets to this. One is that it costs around 2 to 3 grand less than alteplase, but it's important to understand that if you mix alteplase, which we do in most of our stroke alerts, when somebody comes in with a significant deficit even before the CT, but you don't end up using it, it is reimbursed by Genentech. Whereas Tenecteplase, if you mix it and it's not used, it is not reimbursed by Genentech. So you do have to remember that back-end cost. It is effective for large vessel occlusions at a dose of 0.25 milligrams per kilogram. This has been shown because it causes more recanalizations. All the trials showed that it had either slightly lower, not statistically significant, but most of the trials showed same bleeding risk as alteplase. Now, where there is equipoise is in patients with non-large vessel occlusions like coronary aorta or tiny brainstem perforator strokes or thalamic strokes. There just isn't enough data on wake-up strokes and central retinal artery occlusions at this point. Now, can you adopt Tenecteplase? Yes, but there are some few important things to think about if you as an institution are going to do this. You always want to have all the stakeholders involved: pharmacy, emergency room, nursing, and leadership. It's important that you don't have multiple protocols. That is just a mistake waiting to happen. What you don't want to do is have alteplase for non-large vessel strokes, Tenecteplase for large vessel strokes, or 2 different doses of Tenecteplase. You're going to switch over. Consider participating in trials or collecting your data so that you can look at different strokes, just not just the large vessel, but also different types of strokes. And that's the end of my talk. If there's any questions, I'll take them. Thank you.
Thank you, Dr. Yadananapudi, for your talk. I don't see any questions in the chat. The time is 9:34, so we're a little bit above schedule. And we're due for a break until 9:45. Are we gonna go to that time, guys?
Yeah, why don't we take a break until 9:45, let everyone get up and stretch their legs, and then we'll resume with our next talk at 9:45. So
I have Jameer. I'm sorry, the perils of doing things from home is when you have small children. Jameer is one of our social workers at St. Francis Hospital. He works in conjunction with Anna Marie, who was initially supposed to be our speaker, but Jameer was able to fill in for us. So thank you, Jameer, for coming. He's been a social worker for a few years now. I met Jameer as a student at St. Francis, and he came to join us once he had completed his education. And Jameer joined social work because he wanted to join the medical field in a helping way. He likes to interact with the patients on a day-to-day basis, and he's at St. Francis because of the community it brings and its focus on faith. Jameer feels as though his impact on stroke patients is getting them to the safest environment, level of care possible post their hospital stay. So Jameer, you take it away.
Hello. Can you guys see the screen okay?
Yeah,
Yes.
looks good. Looks good, Jameer.
All right, my name's Jamir. Good morning, first of all. My name's Jamir. Thank you for joining me for this presentation about safe discharge planning for stroke patients from acute care. I'm a licensed social worker, as Mania mentioned, in the care management department. I manage the medical social work and acute care discharge planning for our ICU and emergency room patients and spent several years as a stroke social worker. This presentation is intended for stroke care team members involved in the safe discharge planning of patients from the acute care setting. The Centers for Medicare and Medicaid, which is also known as CMS, states that discharge planning is a process used to decide what a patient needs for a smooth transition from one level of care to another. Only a doctor can authorize a patient's release from the hospital, but the actual process of discharge planning can be completed by a social worker, nurse, case manager, or other person. Ideally, and especially for the most complicated medical conditions, discharge planning is done with a team approach, and stroke certainly meeting this criteria. This presentation was created by an acute care social work team and is not intended to be a source of medical information. There is an assumption that hospital discharge planners have a base knowledge and understanding of strokes, so we defer any comments or aneurysms to our medical doctors who presented earlier. I know you're familiar with this graphic. It is important that we, as care team members and discharge planners, understand that strokes are always medical emergencies, and they are emergencies where time is of the essence. This means ambulances and police cars showing up to your patient's home or at the store where they're shopping or at their place of work. It means frantic calls from family members, doors left unlocked, tasks left undone, pets and maybe even kids unattended. No planning done. Stop. Take a note of the stress and fear that the patient and their support systems are under. I'm sure you guys are familiar with the American Stroke Association's 8 Ds of stroke care, which point to the major steps of diagnosis and treatment of stroke and key points at which delays may occur. Each of the 8 Ds in the chain of survival are critical steps that increase the likelihood of prompt diagnosis and treatment of stroke. This presentation is focusing on an equally important 9th day, discharge from the hospital. Effective discharge planning can decrease the chances that a patient is readmitted to the hospital and can also help in recovery. CMS has standards for safe discharge planning of all patients leaving the acute care hospital. There are 13 standards finalized in 2014 and a final rule from 2019. Important for hospital discharge planners to know for their patients, regardless of diagnosis or medical emergency. For stroke patients, I want to draw your eye to 4 standards. Standard 800, the hospital must identify at an early stage all patients who are likely to suffer adverse consequences if no discharge plan is done. Standard 807, a RN, social worker, or other appropriately qualified individual must develop or supervise the development of the discharge plan evaluation. Standard 837, hospital must transfer or refer patients to the appropriate facility or agency for follow-up care. And the final rule for 2019, the hospital must provide patients access to information about post-acute care provider choices, including performance on important quality measures and resource use measures. Discharge planning is a process, and there are 6 big steps. 1, evaluation of the patient by qualified personnel. Usually there are initial evaluations and ongoing assessments. Both are important for discharge planners to follow. 2, discussion with the patient or their representative, POA, or medical proxy, determining what or if any barriers. 4 is planning for home or another care facility. 5, referrals to post-acute care providers. And 6, arranging for facility discharges, home care, and follow-up appointments with a primary care provider or specialist. So what makes optimal Optimal discharge planning is so vital for stroke patients is really the pervasive impact of a stroke. As you all know, stroke occurs when a blood vessel bringing blood to the brain gets blocked or ruptures. Our brain controls our ability to move, feel, think, and behave. This slide lists out and provides a visual of stroke's potential to impact a person's ability to move, feel, think, and behave. Impact can be felt long after the stroke event. CMS Standard 800s focus on adverse consequences. The pervasive impact of a stroke's adverse consequences demands that all stroke patients have a team-oriented discharge plan. To a certain degree, the brain can heal itself after a stroke. With the right amount of rehabilitation, a person's speech, cognitive, motor, and sensory skills can steadily be recovered. The American Stroke Association estimates that 10% of people fully recover from a stroke. 25% have only minor impairments, and 40% have moderate impairments that are manageable with some sort of special care. So a takeaway for hospital discharge planners: always ensure stroke patients are identified as early as possible in their hospitalization to be evaluated for safe discharge planning, as they are likely to suffer adverse consequences if no discharge plan is done. Discharge planning for complicated medical conditions is best managed as a team. Above is a snapshot of hospitals' care teams for stroke. Each member with their own role and scope of expertise provide best care while in the hospital and also evaluate for needs upon discharge. The roles of the care manager, social worker, or discharge planner, depending on your hospital, functions as the primary point person for discharge planning, which meets CMS Standard 807. It is important for a discharge planner to consider how am I, as a discharge planner for a stroke patient, communicating with these team members. Documentation in the medical record is vital for compliance and communication, but also it is strongly recommended to have a stroke-specific rounds. It is one of the standards to be certified by the Joint Commission as a stroke center. At St. Francis Hospital, ours is held daily on the stroke unit with neuro, nursing, and our rehab therapists, our stroke program coordinator, and the social worker who at our hospital is a discharge planner. The hospital rehab team is vital for the evaluation component of discharge planning. This slide has rehab terms on levels of assistance and functioning skills. A discharge planner should be familiar with these terms when reading physical and occupational therapy evaluations. It is important for discharge planners to know that the PCOT discharge recommendation of what a patient will need post-discharge depends not only on how a patient does in an evaluation and follow-up sessions, but 3 other factors. 1, patient's level of functioning prior to the stroke. 2, the support system that they have available to them post-discharge. And 3, the patient's own goals for their post-stroke recovery. The discharge planner must ensure that the patient and or their family or caregiver is actively involved in the discharge plan to get this info. That is documented in the medical record and communicated to team members, usually. I'll give you a few seconds to digest this content of this slide. When we talk about discharge planning, an important question to answer is, where will all the patients get the best post-hospital care and rehabilitation? This question is best answered by the hospital's team evaluation, including a PTOT assessment of functioning, the patient's prior level of functioning, the patient's support system in place at time of discharge, and the patient's own goals for their post-stroke recovery. We'll do a rundown of each level with particular attention to acute inpatient rehab or inpatient rehabilitation facility, also known as IRF, being the most used acronym. The American Heart and Stroke Associations recommend IRF care if the patient can tolerate at least 3 hours a day of stroke rehab. IRFs are a separate hospital or a freestanding building that provides hospital level care for stroke survivors who need intensive rehabilitation. They provide at least 3 hours per day or 5 days a week active rehab. PT, OT, speech, 24/7 nursing, and daily doctor visits. An important takeaway for discharge planners is that every stroke patient should be evaluated for IRF. Does the patient need 3 hours a day of therapy or 5 days a week of rehab to attain their goal level of functioning? And can they tolerate this amount of therapy? This very clear recommendation came from American Heart Association and American Stroke Association in 2016. Based on a multi-year study which strongly recommends stroke patients seek rehabilitation through acute inpatient rehab hospitals instead of skilled nursing facilities, also known as SNFs, for better outcomes. Before we review IRF versus SNF, a few things to know about discharge planning to IRF. Stroke is one of Medicare's qualifying conditions for reimbursement. 60% of the IRF patients must have a qualifying condition, a necessity for Medicare reimbursement. Facilities, liaisons, and admissions offices manage this, but something to know. Other conditions including spinal cord injury, brain injury, and major multiple traumas. A pre-admission screening must be conducted and reviewed and concurred by a rehabilitation physician prior to admission. Also managed by the facility, but hospital clinical and a patient interview are usually two key sources. The pandemic did pose a challenge, of course, to liaisons for in-person interviews. Medicare Part A covers most of the IRF costs of care. For insurances that need a prior authorization, the following is usually needed: history and physical, rehab evals, progress notes, attending progress notes, and nursing notes. 3 days most current is the usual ask for these facilities. It is the same clinical you'll send in your referral to the IRF. Most IRFs do get their own authorizations through insurance. If the hospital stroke care team has determined that IRF is the best discharge plan, discharge planners, get your facility liaison involved as soon as possible. They're great resources, and particularly for patients and families. They love to talk to them and get them in. IRF is one of the level of cares that falls under Final Rule 2019, which is about providing choice and informed performance and quality to help patients make their choice. Medicare has the Find and Compare tool for every level of care under its auspices. Doctors and clinicians, nursing homes, home health, hospice, LTAC, dialysis are all things that fall under this rule. This slide is from Medicare Find and Compare tool for inpatient rehab facilities. There are 16 within a 100-mile radius of Wilmington, Delaware, including 3 in Delaware, which is Wilmington Hospital, Encompass in Middletown, and PAM in Dover. A takeaway for discharge planners: choice as well as quality info must be provided to every patient when a discharge plan to IRF, for a discharge plan to IRF. Medicare's Find and Compare tool is a great resource for choice. So let's do some comparisons of IRF versus SNF, or what we sometimes call acute versus subacute for stroke patients. The average length of stay for an IRF is 15 days versus 32 days for SNF. Stroke patients who went to IRF were able to reside in their homes without readmitting to facility-based care 92 days longer than SNF patients. At IRF, patients have daily physician visits by a doctor who specializes in physical medicine and rehab, which is a branch of medicine that focuses on restoring functional ability and quality of life to people with physical impairments or disabilities. At SNFs, they usually focus on like medicine and geriatrics. Their main focus is on the aging person. For nursing, IRF requires 24-hour rehab nursing. A rehabilitation nurse specializes in helping people with disabilities and chronic illnesses attain optimal functioning, health, and adapt to an altered lifestyle. SNFs provide skilled nursing, which give patients round-the-clock assistance with healthcare and activities of daily living. It covers things like wound care, IV medications, catheters, colostomy care, and tube feedings. Delaware has 3 IRF facilities mentioned earlier and has 47 skilled nursing facilities. The 3 IRFs focus on one level of care, which is acute rehab, while most of the 47 skilled nursing facilities house 2 programs, subacute rehab and long-term care, or as most people call them, nursing homes. There are certainly times when discharge to SNF is the better plan for a stroke patient. This decision is best reached by a team that includes the healthcare providers listed several slides back, and importantly, the patient and their support persons. One of the main deciding factors of SNF over IRF is the patient is not able to tolerate 3 hours of daily therapy. This could be related to their previous level of functioning, extensiveness of the stroke, or the interplay of the stroke with comorbidities. There are also cases where a patient's skilled nursing needs take precedent over the rehab needs, or perhaps don't allow for the time for 3 hours of daily therapy. Discharge planners, of course, always have the patient's insurance on their mind. If Medicare, do they meet the 3 inpatient stay? If a commercial, what facilities are in network and how do you get prior authorization? Long-term acute care hospitals, commonly referred to as LTACs, are suitable for stroke patients whose continuing complex medical care is the first priority. So medically fragile patients on ventilators, those with wounds requiring complex care, those needing dialysis, intravenous chemotherapy, or tracheostomy management are examples of patients who will benefit most from this level of care. Rehab therapies are provided according to the patient's tolerance. These patients often step down to IRF or SNF once medically stable and able to focus on rehab. Discharge planners can consider home health care for stroke patients whose stroke deficits are not too far from their prior level of functioning. Usually these are patients whose stroke was deemed a TIA. TIA may cause temporary stroke-like symptoms, but does not damage brain cells or cause permanent disability. Home care offers skilled nursing, PTOT, and medication management. For Medicare patients, physicians must certify via the face-to-face that patient is homebound. Medicare considers you homebound if you need the help of another person or medical equipment such as crutches, a walker, or a wheelchair to leave your home, or your doctor believes that your health or illness could get worse if you leave your home. And it's difficult for you to leave your home, and you typically cannot do so. Considers you homebound. When you discharge a patient home, one of the best things you can do for your patient is make sure they get their discharge medications, at least 30 days worth, and have a plan for who will prescribe post 30 days. Is it their primary care or a neurologist? Ideally, have a patient's discharge meds given to them beside via meds to beds program, which involve med delivery and bedside education. If med delivery isn't available, ensure discharge scripts are e-scribed to patient's pharmacy of choice, and call to make sure meds are available and determine if any prior authorizations are needed. Some of the anticoagulants like Xarelto and Eliquis have manufacturer coupons available. We have pharmacy reps who provide these. For the first 3 months after an initial stroke, your patient's risk of stroke is 15 times higher than the general population. Each year, 795,000 strokes occur in the United States. Of those, around 23% are recurrent strokes. Taking medication as prescribed is an important tool in stroke prevention. So help your patient be as compliant as possible. If you're discharging a stroke patient from the hospital to home with or without home care, it is important that you have a discussion with the team. The patient and their supports, whether the stroke has impacted their ability to engage in any of the care above, like personal care, household care, health care, and emotional care. A note of caution, male stroke survivors that live alone are at an increased risk of premature death. A study in Sweden followed 1,090 ischemic stroke survivors and for 12 years. 36% of survivors who lived alone died, compared to 17% of those with partners. Among men, the rates were 44% for those living alone and 14% for those living with a partner or other support. Even after adjusting the risk factors such as physical inactivity, heavy drinking, and low levels of education, living alone was still associated with an increased risk of death in the study. Possible causes are that people who live alone lead less healthy lives, are less prone to take their meds, and tend to wait longer before going to the emergency room. As a discharge planner, I know talking with a patient about limited social supports is an uncomfortable conversation, but it's important. It's an important one to have. The American Stroke Association's website, www.stroke.org, has an abundance of resources for stroke survivors, including support groups. The focus of stroke care and medical care in general is to restore a person's health and well-being. But some strokes are so profound, they cause irreparable damage. Stroke is the number 5 cause of death and a leading cause of disability in the United States. Hospice can be the right support for certain stroke patients. It is covered 100% by Medicare, Medicaid, and private insurance for patients who meet the required criteria. It offers hospice nurses and aides, social workers, chaplains, volunteers, and bereavement counselors. It covers all medications related to their primary illness and medical equipment like hospital beds and wheelchairs. There are, of course, criteria for this level of care. For stroke, this includes poor functioning status, mainly bedbound, requiring max assistance to perform self-care. Also, the inability to maintain hydration and caloric intake with either recent weight loss, pulmonary aspiration, calorie counts, documented inadequate caloric/fluid intake, or dysphagia severe enough to keep the patient from eating and drinking enough. Documentation of medical complications like pneumonia, UTI, sepsis, severe skin breakdowns. Often hospice is decided upon a stroke patient after a period of limited or no recovery, not necessarily right for acute care. Discharge planners at every level of care must be aware of it as a potential resource for patients. I want to mention that COVID-19 emergency declaration blanket waivers for healthcare providers issued by CMS in March 2020, and most recently updated earlier this month. These waivers have impact across the health system. Discharge planners, important for you to be familiar with them as they do impact almost all levels of post-acute care. As they directly relate to what we are talking about today, there are 3 waivers in place as of today. The 60% rule for IRF qualifying conditions waived, 3-hour rule for intensity of therapy at IRF waived, and 3-day inpatient stay for SNF waived. Review these with your compliance department and your post-acute care providers. Check the CMS website regularly to determine which waivers still are active. So before I end our presentation, just a quick recap of what we discussed. Ensure patients are assessed for a discharge plan ASAP. Discharge planning is best done as a team that includes multiple healthcare disciplines and the patients and their support persons. We reviewed the 6 levels of care available for stroke patients after the hospital, which is IRF, SNF, LTAC, home health, outpatient, and hospice. IRF is the recommended level of care for stroke patients, so rule this out before considering other levels of care for stroke patients. Don't forget that we have to ensure our patients have choice and the quality info needed to make informed choices. Medical care find and compare tools are available for every level of care and are good resources for this. And lastly, discharge planning is a demanding, task-filled process with tight deadlines, but strokes are one of the most stressful, life-changing things a person will ever experience. No one plans for them. I think compassionate, patient-centered discharge planning goes a long way to alleviate the stress and get your patients on their road to recovery. And thank you. That's it.
Thank you, Jameer.
Uh-huh.
That was a wonderful presentation. I don't see any questions in the chat box for participants, but Jameer will be available for questions later on at the end of the presentation, the conference, I should say, as well. And Dr. Dresser, are you going to introduce our next panelist?
Yes, thanks, Amelia. Jameer, that was an excellent talk. Thank you so much. And we really appreciate Jameer's efforts for our stroke patients at St. Francis. He makes the appropriate disposition of them much easier, and always does it in a very good mood. Our next speaker has not signed on yet, so technically has a few more minutes for Dr. Wad to join in. So we will, I think, in the absence of any questions, just take a few minutes and wait for Dr. Wad to join us. So he is scheduled to start his talk at 10:15. So we will just take a few minutes if anyone needs to stretch their legs, and we will be starting back at 10:15. There actually a question just came in, Jameer, if you're still on. Somebody just asked support for caregivers, I guess, as part of discharge planning.
Can you hear me? Hello?
We can hear you.
What do you, so support for caregivers, what do you, like, is that a question?
That was it, Jameer. It was support for caregivers ? I guess just asking is that something that is done as part of the discharge planning? Do folks make an effort to try to get any type of, I guess, psychological support or physical support for the caregivers?
Like, what steps we take to get physical supports for the caregivers? I'm sorry, I'm just confused.
Yeah, that was the question. It was 3 words: support for caregivers. Any thoughts on that, Jameer? Maybe.
I mean, we definitely take every effort to provide support for caregivers, like their family, their POA, who they have like listed, who they want to be involved in their care, whether that be family, whether that not be family. And the support for, I guess, like, what type of support do caregivers have? Like, care managers and the interdisciplinary team at the hospital support them every step of the way, by talking to them, giving them counseling, empathy for what's going on with their loved one, and just giving them the resources necessary to get to the best level of care. I think we have a lot of tools in place to give them resources that make it easy for them to make informed decisions on the discharge plan for their loved one. And they definitely have a lot of support at St. Francis, in particular with social work and the chaplain. So we're readily available to support them in all their needs and questions.
Yeah, thanks, Jameer. I can attest to that. You guys do a great job. There's one other question that maybe you can answer online, Jameer, but just to keep on schedule, I'll move on to our next speaker, which is Dr. Louis Wad. We're very fortunate to have Dr. Wad join us today to speak on technology and stroke rehabilitation, which is always a fascinating topic. Dr. Wad is the director of the Neuromotor Recovery Laboratory and an associate faculty member at the Center for Neurophotonics at Boston University. Dr. Wad is a member of the research faculty at the Stroke Wellness Institute at the Spaulding Rehabilitation Hospital and he's an associate in the Department of Physical Medicine and Rehabilitation at Harvard Medical School, and an associate at Paulson School of Engineering and Applied Sciences at Harvard. Dr. Wad is originally has local connections, and he received his doctorate of physical therapy and his PhD from the University of Delaware. And we are very pleased and fortunate to have Dr. Wad contribute to our conference this morning. So thank you for joining us, Lou.
Thank you, Dr. Dresser. Can you see my PowerPoint?
I can. Looks good.
Awesome. All right. All right, thank you for the introduction as well. Everyone, it's a real honor to be with you here today. As Dr. Dresser mentioned, I am a graduate of the University of Delaware in 2014, completing both a doctorate in physical therapy and a PhD in biomechanics and movement science. Dr. Scholz was actually one of my professors, and words cannot express how influential he was in my development as a physical therapist and a movement scientist. To be able to speak at a conference named after him is actually very humbling, and so thank you for this invitation today. So the focus of my talk is on rehabilitation technology after stroke. My original intention was to go over a number of different technologies that my research team has been fortunate to work on, but for the sake of time today, instead of going wide, I decided to focus and go deep on just one of those technologies. That's soft robotic exosuits for propulsion retraining after stroke. But I will give an overview of how our team approaches the development and translation of rehab technologies. And of course, I'm very happy to answer any questions at the end about some of the other technologies that we are working on. All right, so to dive in, if you spend much time around people post-stroke, as I'm sure most people on this call have, one of the first things that jump out at you is that they walk rather slowly. And the more in tune that you become with their movement patterns, another thing that will jump out at you is that their gait tends to be very asymmetric, both spatially and temporally. The length and width of their steps and the time that they spend on each leg, if you measure these variables across the legs, there's going to be an asymmetry. And as a consequence of their slow walking speeds and their asymmetric walking patterns, people post-stroke require a substantial amount of energy to walk. Their gait is very effortful. I'm showing you here is the difference between stroke participants and controls, a preferred walking speed and a fast walking speed in terms of their energy cost of walking. But what I think really gets the point across is that their poor walking economy contrasts heavily with the fact that human bipedal walking has evolved over 8 million years to be among the most economical gait patterns on Earth. Healthy walking requires about 0.18 milliliters of oxygen to move 1 kilogram of body weight 1 meter. In contrast, people post-stroke require 3 to 4 times that amount, making them less economical than the quadruped ancestors that we are thought to have evolved from. And those ancestors, by the way, were not chimpanzees, as shown off to the left here, but a creature thought to have a similar gait pattern as a chimpanzee, just for reference. Now, our team at Boston University spends a lot of time thinking about the evolutionary mismatch between how people post-stroke walk and how those walking patterns are not really well suited for many modern day tasks and environmental contexts. And we use this background to think about how wearable sensing and actuation technology can be used to both quantify and treat post-stroke walking impairments. Ultimately, what our work is focused on is a cross-disciplinary integration focused on developing, studying, and translating new rehabilitation technologies that can augment the abilities of the stroke clinician. Across all of our projects, we have engineers working alongside clinicians, and this is true not just in our lab, but also our entire research collaborative that spans Boston University, Harvard University, Spalding Rehabilitation Hospital, and Whittier Rehabilitation Hospital, for those who are familiar with the Boston area. And we are really fortunate to be in that setting that we are currently in. Now, in addition to many of our failed attempts at developing and translating rehabilitation technology, our team has been fortunate to lead and be a major part of several successful efforts in the last 5 years. These include leading clinical trials of novel textile-based robotic technology for post-stroke rehabilitation and other applications. And just last week, we finalized and signed a 5-year sponsored research and development agreement with MedRhythms, a music-based digital therapeutic company whose post-stroke device was actually just named by the FDA as a breakthrough device for post-stroke rehabilitation. And currently, we have what I think are two really promising post-stroke technologies in our pipeline that are based on functional electrical stimulation. Early studies were conducted right here at the University of Delaware, right by you guys, as well as wearable sensor systems for point-of-care diagnostics and movement phenotyping. But as I introduced earlier, my talk today is going to focus on soft robotic exosuits, but feel free to ask any questions about any of our work if interested. Now, before I dive in, I thought it would be helpful to take a step back and give you some insight into how we approach technology translation in our lab. And our work loosely follows the following trajectory. But typically, our team begins with this general idea, and to make it come to life, we use an iterative research and development process that's focused on development and then validation of the new technology. And the ultimate goal is making something that is usable by the intended end user, either a clinician, a patient, a caregiver. And importantly, this phase also tests mechanistic fidelity. It actually does what we want it to do. And many times we fail that test of mechanistic fidelity. Now, technologies that achieve that goal and that we think have rehabilitative value, they progress to the evidence generation side. Naturally, we don't jump right into multi-site pivotal trials. Rather, we do our due diligence with a progressive staging of studies designed to test safety, feasibility, and then ultimately efficacy of not just the technology, but the rehabilitation program built around that technology, which I often argue with my engineering colleagues is just as important as the technology itself. Right? Now, without getting into the details, our device development work begins with lab-based platforms. These are off-the-shelf sensors and actuators that are kind of thrown together to allow us to develop control algorithms and then define the hardware requirements for what will eventually become the functional prototypes. And functional prototypes don't necessarily look sleek and polished like what a commercial device would look like, but they function as intended. And this allows us to start our first stage of evidence generation, which is labeled here as consideration of concept. This eventually progresses to the development of the concept if the evidence is there. And as these prototypes mature, and if, big if, the clinical evidence looks promising, the design is fixed for larger scale multi-center or single center clinical studies, labeled here as demonstration of concept and proof of concept. Now, although I'm presenting these stages of progression in a linear fashion, the process is quite iterative, both within and across these stages. Now, the core focus of our work in post-stroke rehabilitation is on walking. And to transition to discussing our propulsion augmenting exosuit technology, what I'm showing you here is a single cycle of walking broken down into its three parts. And for anyone walking on two legs, this basic underlying pattern of body weight support, propulsion, and limb advancements there. The challenge is that disease or injury to the neuromotor system disrupts the execution of any one or more of these tasks or the transition across the tasks. And when this happens, physiological walking, that is typical healthy walking behavior, is not achievable without some form of intervention. And the focus of the technology that I'm presenting today is on that middle propulsion subtask. When I say propulsion, I mean the act of creating forces that lead to movement. If we take a moment to think about propulsion outside of walking and stroke rehabilitation, our lives rely on technologies that we have created to help us with the act of propulsion. Technologies that do a large part of the work required to create the forces needed to move us around our world. Before COVID-19, I probably would have joined you guys in person in Delaware by taking advantage of jet propulsion technology. Those who drive to work every day, you rely on car propulsion technology. And if you're willing to brave the streets of Newark, you can bike to work every day, and that will augment your personal propulsion abilities, allowing you to travel faster and farther than you would be able to on your own. And for individuals with neuromotor impairments, we have built impressive propulsion technologies that compensate for lost propulsion function. And these technologies can range from a wheelchair that you see in the back of this video to a powered exoskeleton that can fully support an individual's body weight and help them walk again. But of course, normally we don't need technologies for propulsion. We are neuro mechanical systems that are built for propulsion. With every step that we take, different groups of muscles are sequentially activated in a highly coordinated way, causing our limbs to push off the ground and creating the ground reaction forces that move us about our world. Said another way, propulsion is acceleration. Clinically, we should be very interested in how people accelerate. And that's because we are really interested in walking speed. Walking speed is associated with health, function, quality of life, fall risk, mortality. It's considered a sixth vital sign. Faster people are healthier people. They live longer. But to get to a fast speed, we need to accelerate. We need to create propulsive forces. If we freeze this animation here in a position that we call double support, which is when both feet are on the ground at the same time, what we actually have going on here is a balancing act of acceleration and deceleration. When that lead limb strikes the ground in front of the body, it is pushing the ground away. And because every force has an equal and opposite reaction force, the ground pushes right back, and the orientation of that force causes the body to decelerate. The ground is making you slow down. Now, thankfully, you have another leg behind you that is also pushing the ground away, with the ground pushing right back, and this time the ground is accelerating you forward. It's that anteriorly directed ground reaction force that we call the propulsion force, and that's what we measure in our lab. Now, fundamental to that physiological propulsion is the ability to activate the plantar flexor muscles of the trailing limb with the right timing and magnitude as the body arcs over and in front of the leg. I'm going to take a second to explain that. So bipedal walking, we know, consists of alternating periods, excuse me, alternating periods of single limb support and double limb support. Okay? And the body center of mass arcs over the stance limb. Think about this as the foot and the body's arcing over that stance limb during single limb support. And it does so like an inverted pendulum, if you can envision that. And because of this, gravity can do much of the work to advance us forward once we get to that high point up here. The problem is, what goes up must come down. And as gravity brings us down, during the double support phase here, the body center mass is directed downward and forward. And something has to happen to redirect the body upward and into the next gait cycle. Now, we know that when that leading limb strikes the ground, it stops the body from continuing toward the ground, right? And that acts to redirect the center mass upwards. But as I just described in the other slide, that leading limb also applies a braking or decelerating force. And that's accounted for by the trailing limb. How does the trailing limb account for it? Well, in healthy walking, it's the plantar flexor muscles of that trailing limb that are primary actors that restore the forward acceleration of the body. That is, that restore propulsion. Unfortunately, in people with post-stroke hemiparesis, the paretic plantar flexors are markedly weaker, generating a maximum voluntary force that is 40% less than their non-paretic plantar flexors. On top of that, the neural drive to the paretic plantar flexors is reduced by over 27% compared to the non-paretic limb. So not only do the paretic plantar flexors have a reduced force generating capacity, but people with post-stroke can't fully access that residual capacity. And as a consequence, if we plot the anterior-posterior ground reaction force, remember the anterior portion here is the propulsive force, what we see is a propulsion asymmetry across the two limbs. And impaired paretic propulsion has important biomechanical and functional consequences for our patients. Okay? Propulsion impairment is associated with a higher cost of transport, slower walking speeds, and a reduced ability to walk far distances. And I'll take a moment to take these one at a time. The figure on the right here shows the relationship between propulsion by the paretic limb on the x-axis and walking economy on the y-axis. So this is the energy cost of walking on the y-axis. And what I'm showing you here is 4 data points for 8 different individuals post-stroke. And what you can see is that propulsion is tightly coupled to energy cost within an individual and across individuals. Those that can generate more propulsion from the paretic limbs consume less energy per meter walked than those that produce less propulsion from the paretic limbs. And within each individual, we'll take this individual who has a paretic propulsion between 1 to, let's say, 5% of their body weight. Lower propulsion is associated with a higher energy cost of walking than a higher propulsion that can be produced from that paretic limb. And we have other data that shows that as well, but for the sake of time, I'll just skip ahead. Propulsion asymmetry is also associated with impaired walking distance. Shown here is the relationship between propulsion and walking distance. This is the 6-minute walk test for those who are familiar with that test. And what I did here is I broke down the subset of people post-stroke, about 60 people here in this sample, based on walking distance cutoffs reported in a paper by George Falk in 2017 in the journal Stroke, that classifies people as home ambulators, those that walk under 2,500 steps per day, and those who are community ambulators, those who walk over 7,500 steps per day. And if you just take the average propulsion in a very gross fashion, average propulsion of these community ambulators, these people that can walk far distances, it's about 10% of their body weight that they're able to generate in the anterior direction. Home ambulators, though, 3% of their body weight. And if we look at walking speed, you can see a similar thing. Those who are home ambulators or classified as home ambulators by walking speed, they generate less than 4% or 3.55% body weight compared to community ambulators, over 14% body weight. And this is an intuitive relationship because propulsion is acceleration, acceleration is speed. If you can't generate propulsion, you're not going to be able to accelerate, you're not going to be able to walk fast, you're not going to be able to maintain the speed for a long distance. And this is quite important clinically because the 6-minute walk test, as well as walking speed, they're among the best predictors of community walking activity after stroke, shown here on the y-axis. This is a metric that you take a step activity monitor, like a Fitbit or a stepwatch, you put it on the person, you send them out to the real world for 7 days, you monitor how many steps they take in the real world over that time period. And that's related to this clinic-based test of the 6-minute walk test. So in summary, when you think about the majority of people post-stroke that are walking, they're not achieving propulsion through that physiological strategy that we were just talking about. They lack the ability to activate the plantar flexor muscles with the right timing and magnitude as the body arcs over and in front of the leg, right? Propulsion of the body is achieved via a very inefficient and labor-intensive strategy. Here, this person's leg is on the impaired leg is on the far side toward the street. And if you look closely, you can see that instead of plantar flexing her ankle and pushing off the ground, she's actually lifting her entire leg using a very inefficient, slow, and asymmetric walking strategy. And this is the daily reality for the many millions of Americans who survive a stroke only to suffer from walking impairments that reduce physical activity and lead to a poor quality of life. Now, you would think that given how important plantar flexion is to physiological propulsion, the physiological propulsion that's needed for that fast, stable, and efficient gait, that there would be a number of interventions available to restore plantar flexion during walking. But, and I don't need to tell all of you this, if today you visit any of the major rehab centers across the country, you're going to see that there are very few clinical interventions that are focused on restoring that plantar flexion control during walking and retraining propulsion ability. But perhaps more importantly, not only do we lack effective propulsion interventions, but some of our standard interventions actually impede propulsion. For example, among the most common interventions that are used after a stroke is the ankle-foot orthosis. The AFO is a crucial piece of assistive technology that can assist the first and last of these subtasks by providing stability during the stance phase of walking and helping with ground clearance during the swing phase. But because an AFO constrains the movement of the ankle, an AFO is actually detrimental to that physiological propulsion strategy that I was just talking about. AFOs constrain plantar flexion. Plantar flexion is needed for physiological propulsion. So in many ways, as soon as an AFO is prescribed, that recovery of physiological propulsion is unlikely. Now, I'm not saying avoid AFOs. Boo has never said that. What I'm saying is AFOs are a crucial tool for facilitating safe and independent walking in people with post-stroke hemiparesis. But I think our goals need to go beyond safe and independent walking. To maximize those long-term gait outcomes, we need interventions that can provide the stability and ground clearance support of AFOs, but not at the expense of propulsion. If our patients can't propel normally, the resulting gait compensations are going to reduce their walking speed. They're going to bound their walking speed, increase the energy cost of walking, and ultimately constrain real-world physical activity. And this leads to our team's central hypothesis that in people with post-stroke hemiparesis, soft robotic exosuits that operate in parallel with the impaired pedic muscles can functionally restore the plantar flexor function that's crucial for propulsion, and by extension, reduce the energy cost of walking, increase walking speed and distance, increase physical activity, and ultimately improve the quality of life of our patients post-stroke. And over the last 6 years, our team has progressed from the development and validation of the foundational exosuit technology to developing a novel gait training program that's designed to leverage unique properties of that technology to target deficits in propulsion. And our current work focuses on progressive staging of pilot studies before eventually launching into a multi-center trial. And as I overviewed generally to start this talk, our work began with lab-based platforms, transitioning to functional prototypes, and currently we're using FDA-approved clinical devices. And for the rest of this talk, I'm going to skip over the technology development and instead overview our early clinical studies that were focused on biomechanical validation and therapeutic feasibility. But we are relatively quite early in the evidence generation pathway. Right? So now our first studies that were examining that mechanistic fidelity, examining the immediate acute biomechanical effects of an exosuit on post-stroke walking, our primary interest was answering the question, does the provision of external forces to the pedic limb through this soft human-machine interface produce the biomechanical effects that we expect? And this included studying the effects of not just the provision of plantar flexion during the stance phase, but also providing the active dorsiflexion assistance during the swing phase that our patients need, right? And what I'm not showing you here is there's also a mechanism in place as a passive mechanism to control the medial lateral motion of the ankle. And we can talk about that offline if people are interested. And so I'm going to briefly overview some of that early work. And if you look over here, in terms of improved net ground clearance, on the y-axis is the dorsiflexion angle during the swing phase, right? And when the exosuit's unpowered, in the sample of about 9 people post-stroke, they have about -2 degrees of dorsiflexion. So the foot is 2 degrees plantar flexed on average in this sample during the unpowered condition. So that's the characteristic drop foot. You power on the exosuit, and on average, people have 4 degrees of dorsiflexion. So in many ways, when you just power on the anterior cable here of the exosuit, you're going to have the similar effects of a drop foot stimulator or an ankle foot orthosis in terms of the swing phase effects. But when we move into the plantar flexion system, the system that actuates in parallel with the pedic plantar flexors here in the back, what you see is an improvement in propulsion symmetry. Going from the unpowered to powered condition, you have about a 20% reduction in propulsion asymmetry in, again, the sample of 9 people post-stroke. Now, early in the talk, I said that propulsion asymmetry, the asymmetry in propulsion, was linked to a high energy cost of walking. And in support of that relationship, when you look at the effects on walking economy of powering on the exosuit, we see a 30% reduction in the metabolic burden of walking with post-stroke hemiparesis. 0 here is the normal energy cost of walking, about 0.15 milliliters of oxygen per meter walked. And in this small sample of people post-stroke, we saw that improvements in propulsion asymmetry here on the x-axis, with towards the right is more symmetric, were associated with reductions in walking economy. Down is more symmetric. So those who were more symmetric had better improvements of walking economy. Now, moving beyond our primary outcomes, although we're helping the ankle, we believe that deficits in plantar flexion and dorsiflexion of the ankle are primary deviations responsible for compensations up the kinematic chain. And specifically, we were interested in looking at the effects of walking with the exosuit on hip circumduction and hip hiking during walking. Right? And if that understanding is true, then if we improve plantar flexion and dorsiflexion with the exosuit, we should see a reduction in these presumably secondary compensatory deviations. Right? And as hypothesized, when the exosuit was powered on, we did see those reductions. And let me walk through them individually. So for circumduction, what I'm going to show you in a moment are the position changes of the foot, as if you were standing above the person, looking through their head, down at their foot, moving in that frontal plane. Right? In the gray here is walking with the exosuit unpowered, and in the red is walking with the exosuit powered. And in the stance phase, the limb goes back, and in the swing phase, it sees out, it circumducts on the paretic side, whereas the non-paretic limb, there is no circumduction. And you can see this is one person here, and this is the average across 7 people post-stroke. In this one person, you see that circumduction reduced by about half, and across the people post the entire sample, it's about a 20% reduction in circumduction. In terms of hip hiking, we see a similar 27% reduction in hip hiking. Typically, when you walk, the pelvis is supposed to drop a little bit. In people post-stroke, it rises a good amount. And with the exosuit powered on, it reduces by about 27% relative to that standing position. And we have other studies examining the acute effects of an exosuit on neuromotor control outcomes. Studies ranging from muscle modules during walking, where we see like an increase in modules, but I'm not going to get into these details now, but happy to answer questions. We're also using functional near-infrared spectroscopy or imaging to look at changes in cortical activation associated with cognitive effort. During exosuit augmented walking, we're seeing a reduction in prefrontal cortex activity, suggesting improvements in walking automaticity. But again, won't get into those details unless asked. And so for the interest of time, I'm going to transition to speaking about our early studies on the therapeutic effects of the exosuit technology. This is the idea that walking with the exosuit during gait training can lead to long-standing benefits that persist beyond the use of the device. When you get rid of the device and do a follow-up assessment, is there an improvement in their walking pattern? And so one of our first questions that we asked when making that transition from a development-focused technology to a clinical-focused technology was, can people post-stroke utilize the assistance to improve their walking speed and distance? Basically, we're asking, can people use this technology to achieve more repetitions and a higher intensity during gait training? So walking speed and distance. And in a recent paper published in IEEE's Journal of Engineering, Medicine, and Biology, we reported the results of a small initial study with 5 people post-stroke, where we did observe clinically meaningful improvements in both speed and distance outcomes. Right? And now, motivated by that evidence, we started thinking about how we can use the exosuit technology to retrain propulsion and walking speed during post-stroke walking. And currently we have an ongoing early stage multi-center study that's testing a standardized gait program that we refer to as the Robotic Exosuit Augmented Locomotion, or the REAL gait training program. And I'm happy to answer questions and share details later on, but briefly, the REAL training aims to leverage unique aspects of the exosuit technology while drawing on contemporary principles of neuroplasticity and motor learning to provide high-intensity, task-specific, and progressive gait training with special focus on cue-directed training of the gait parameters associated with propulsive force produced by the paretic limb during walking. Now, taking advantage of the portability of the exosuit technology, REAL training allows us to do testing in a variety of different environments. We begin with lab-based evaluations in a controlled setting where we can assess outcomes with precision. And then we transition to more open environments for training in the clinic. And we even have some studies are going on in the community right now where people are actually using the technology in the real world. Shown here is a picture of a person post-stroke walking with the device during the Bionic 5K in Cambridge, Massachusetts. So now another aspect of the exosuit technology that the REAL training program takes advantage of is that because it's so lightweight, with the majority of the components worn on the limbs made from soft textiles, it has the ability to quickly get out of the way of the user by simply turning off the power. That is, it has a transparent mode where you turn off the power of the device, and it's like you're walking with a light backpack on your waist. It's about 5 kilos, that little waist pack, and nothing on the limbs. And because of this property, we can use a training mode that we call intermittent assistance, where we interleave periods of walking with and without the exosuit assistance. And this allows us to leverage post-adaptation periods to maximize motor learning during the training. And I can answer questions on that later on. Now, because the study is ongoing, we don't have much in the way of data, but I did want to highlight some of the statements made by the few participants we've seen so far. They say, I didn't think I could walk that fast. say, I wish my wife could see this, and this person's wife did come see this. We invited her over to watch the last few visits of this participant. I wish I was able to practice like this earlier. This person is referring to, this is a person in the chronic phase. He's about 3 years post-stroke. He was wishing that he could use an exosuit in the earlier inpatient phases. Other people have talked about how they feel renewed in terms of their walking ability. They feel like they're walking in a very different way than they've been able to for years, and they self-initiate walking in their neighborhoods and around local tracks. So just some comments from participants. Now, there's two data sets that I do want to show very briefly. This is a single subject consideration of concept trial that we published in Frontiers in Neurobotics earlier this year. This is a very interesting case study in the sense that this person came into our lab over the course of 2 years for exosuit development, a total of 44 visits over those 2 years, spending about 15 to 30 minutes walking in the device. And these weren't training studies. These were just testing different device components, different control algorithms. And over this time, he had a very stable walking speed. And we just assessed the 10-meter walk test at random visits over this period of time. And you can see this walking speed is about 0.96 meters per second, well below the age predicted comfortable walking speed for this individual, which is about 1.4 meters per second. When we started doing these training studies, he's like, I want to be the first participant in your training study. Please enroll me in your training study. So very much a sample of convenience in that regard. But we brought him in and we put him through 5 days of this real gait training program, this robotic exercise augmented gait training program. And from pre-eval to post-eval, in terms of comfortable walking speed, we see a substantial increase after those 5 days of training, larger than the minimal clinically important difference. Look at maximum walking speed, we see the same thing, a large increase, well above the MCID. 6-minute walk test, again, another large increase, well above that MCID. But more excitingly was the therapeutic change in his propulsion biomechanics, with substantial gains in the anterior grand reaction force, pre-eval to post-eval, both measured without the device, his baseline abilities, pre and post training, as well as point metrics related to that propulsion function. And of course, as I mentioned earlier, this work is still in the very early phases of evidence generation. Our focus is still on developing and refining the key elements of the exosuit augmented training. And over the next couple months and years, we're going to share some more studies. We have a current randomized control trial we have started. This is a feasibility study that we ran before, where we brought in 4 people post-stroke to do training with this real gait training program. Then after an 8-week washout, they transitioned to control training, and we had people start in the control group and then transition to real training. And we're looking at like trajectory of changes, seeing if we can make predictions of how long people need to train with the device in order to improve, understanding the baseline characteristics of people that improve, like a responder, non-responder analysis, using all of this to inform the larger multi-center trials. But the data so far has been quite promising. And this is happening in parallel with industry-sponsored research, because we said Rework Robotics has sponsored some of this research, working with a fantastic group of PIs across the country, Dr. Ringerman at Ability Lab, Karen Nolan at Kessler Rehab Hospital, Dr. Gerard Francisco at Tier Memorial Hermann, Dr. Esquinazzi over at Moss Rehab, working very closely with these PIs on multi-site evaluations of the safety and feasibility of using the technology in the real world. Okay. And so with that, I just want to say thank you for the opportunity today, and happy to share more of the work that we're going to be doing in the next couple months to years. We have a number of papers that are in the pipeline that are coming out, and happy to share that with you all in the coming time. Thank you.
Yeah, that was great, Lou. Very, very interesting stuff. I don't see any questions right now, but let me ask you a question if you don't mind. So, it's interesting to me that the people can improve even when you remove the exosuit. What do you think is the basis of that? What is actually happening to them that lets them to get better after the suit is removed?
Yeah, so I think any kind of training is going to improve people's walking speed and their capacity to move. But I think the unique aspect of the exosuit is it forces them to walk and spend more time on that paretic limb, use that paretic limb to generate a push-off force. In many ways, it's like constraint-induced movement therapy, but not quite constraint-induced movement therapy of the lower extremities. One key point related to that, though, is the exosuit does not power movement. It augments movement. So we're delivering forces. It's a soft device, right? Soft textiles. So when we pull on those textiles, we're compressing that soft tissue. There's very low stiffness. So we can't generate high forces. It's not like a rigid exoskeleton that can power the movement of the limb throughout the entire gait cycle. We deliver about 12 to 30% of the biological torque that our muscles produce via the exosuit. So if a person was completely paralyzed, for example, this cannot help them walk. This is not possible. This can't resist gravity. It can't power movement that's completely lost. So what we end up doing, the way I think about it is like if you're pushing a child on a swing, for example, there's a point in time that if you deliver the right amount of push, you don't need to deliver a lot of force in order to keep that swinging back and forth. That's kind of what our exosuit does. At the right time, very strategic timing, we deliver a little bit of a force from those plantar flexors, in parallel to those plantar flexors, that powers movement. And in contrast, a rigid exoskeleton that defines a trajectory, it's kind of like holding onto that swing and running back and forth, back and forth. It requires a lot of force, a lot of power. So our exosuit doesn't do the latter, it does the former. Slight tap at the right time. And that requires, so what ends up happening physiologically, it's a combination of, it's like a cue. You think about like it's a cue to spend more time on that leg, but there's also an entrainment to that mechanical perturbation. Some work by Neville Hogan's group at MIT has shown that if you apply a periodic delivery of plantar flexor torque to the ankle as a person walks, it doesn't matter when you apply in the gait cycle, as long as it's periodic, a person will naturally entrain to that mechanical perturbation. They're going to reorganize their gait pattern around that plantar flexor torque and fire their plantar flexors, generate ankle torques with that assistance. In many ways, I think it's a product of minimizing energy expenditure. One of the control principles underlying human movement is energy reduction. Giovanni Borelli, the father of modern biomechanics, he has a beautiful quote that I love: "Wise nature seeks economy of effort." And I think that underlies this in many ways. So once you show a person post-stroke that they can walk with a slightly different gait strategy that's much more efficient, they want to walk with that much more efficient gait strategy. And then with more repetition, and if you use these principles of neuroplasticity, like high intensity, task-specific practice, high repetition, I think that's going to reinforce that gait strategy in a very meaningful way, compared to like if you just let the robot do the movement for you, and then you have that neuromuscular slacking that's dominated and really killed the first generation rehab robotics in terms of the clinical efficacy at the end of the day. Yeah, I'll stop there.
Yeah, it's that's fascinating stuff. I really look forward to see how far you're able to get with this. It sounds very promising. Lou, there's a question in the Q&A. I can read it, or can you access that? If not,
yep.
I can read.
Yeah, I see it here. So thank you, Laura, for the question. So I'll read it out loud. So this looks like a great device. I'm still seeing some hip hiking. Is anyone developing something similar to assist with a large group of femur muscles to bend the knee and avoid the hip hike? So one thing I'll say to start there is that data that I was showing about the reduction in hip hiking and circumduction was immediate acute effect. So it's a person is walking post-stroke and they've got their pre-existing compensatory pattern, and then you press the on button and you're assisting plantar flexion and dorsiflexion. And as soon as you press that on button, there's an immediate reduction in hip hiking, an immediate reduction in circumduction. And for our group, it was an expected change in the sense that we think that hip hiking and circumduction are compensations. They're secondary to deficits distal in the chain, distal in the kinematic chain. But people also is like, well, you're just assisting the ankle. How important is the ankle to walking? So we think that data shows that it is a chain, and it's important to appreciate that there are secondary deviations to primary deficits. Now, one thing that we do think is going to happen, and this is part of our ongoing multi-site trial, but I don't know what the data shows yet, so give me a couple more months and I'll tell you what happens, is with repeated exposure and training with the device, that immediate improvement is going to be larger and longer lasting and won't need the device anymore. So just wanted to clarify, those are the immediate biomechanical effects, more like an orthotic effect. We're really interested in that therapeutic effect that's going to happen over the longer term. So fingers crossed, we'll see where it goes.
There was another question there as well, Lou.
Yep, Kayla, have you noticed a difference between motor learning using cable-driven soft exercise versus FES? Does one tend to be more effective than another, or is it patient-specific to who responds better to what intervention? Kayla, do you want to join our research team? We actually have a project that is asking that question right now. It's comparing, maybe many people on this call are familiar with the FAST FES study that happened at the University of Delaware, led by Dr. Stuart Binder-McLeod and Dr. Darcy Reisman. That was a project that I was working on as a PhD student, so I have a lot of familiarity with functional electrical stimulation. And one question that we always have is one better than the other? But really the question I have is there a synergy? So you have a cable-driven device that externally moves the limb and provides a certain amount of assistance. And then you have electrical stimulation that can happen in parallel with that. That will activate and potentiate the neuromotor system to better respond to the training. Now, one of the drawbacks of electrical stimulation is it depends on the strength of the muscle, right? So if and the fatigability of the muscle, and in people post-stroke, they're weak and they don't have the ability to activate that muscle over time. So there might be a synergy between FES and exosuits in that regard. Yeah. But I don't have an answer yet, but we are studying that question right now. Well, thank you again, everyone, for these fantastic questions.
But thank you, Lou. That's really fascinating stuff, and I really appreciate you taking the time out on a weekend to share your work with us. So, Mania, maybe you could introduce our final speaker of the day.
Yes, I can. Good morning, everyone, again. I'm introducing Dr. Anna Cervantes Arslanian. I hope I didn't murder that too bad. She's doing a presentation on COVID-19, stroke, and other neurological conditions. She is the clinical vice chair of the Department of Neurology and the chief of the divisions of neurocritical care and neuroinfectious disease at Boston University. She is an assistant professor of neurology, neurosurgery, and infectious disease at Boston University School of Medicine. Her research interests focus on neurologic infections, in particular cerebral vascular complications of infectious diseases.
All right, thank you so much. Let me share my screen. All right, wonderful. I hope everyone's able to hear me. So I'm so thrilled to be able to speak with this group today. I looked on PubMed yesterday, and there were officially over 3,000 papers on neurologic complications of COVID, and well over 1,800 just on stroke and COVID. So there's more literature out there than any one person would be able to kind of digest. Myself included, though I do think I've probably read most of those 1,800 stroke papers. Today, I really hope to educate everyone about what's currently known about the neurologic impact of COVID-19, partly through my own experience caring for patients as a neurointensivist and stroke doc, and also from my review of the literature. And so I'll kind of hurry through the things that are not related to stroke and really focus on stroke, because that's the interest, obviously, of all of us in this group. I don't have any disclosures except to say that I'm a consultant to the CDC for their CISA project, where we review complications or concerns that the public or healthcare providers might have about any sort of neurologic complications in particular that may happen after COVID vaccination. So my objectives today, I'll talk about the breadth of neurologic complications in COVID, really focusing on cerebral vascular disease. I'll talk about the proposed pathophysiology of neurologic complications in COVID. And I'll talk about treatment strategies related to COVID in terms of trying to prevent stroke and treat stroke once it's happened. And maybe we'll have time to talk about some controversies and some upcoming research. So at this point, my 3-year-old knows that SARS-CoV-2 is a coronavirus, so I'm not going to spend much time on this slide and kind of get on into talking about neurologic complications. And I'll start a little bit with the history, although at this point we all know that history isn't too long. So this is the first report of a neurologic complication, which was obviously released pretty early on in the pandemic. It was a single center study. They reported 214 patients at one hospital in Wuhan, and they divided up patients by their severity of respiratory complications. And what they found in their group was that 36% had a neurologic complication, which in many were vague symptoms that come with all sorts of viral illnesses like dizziness and headache. But they also noted, certainly things of concern like impaired consciousness, seizure, and stroke. In particular, they mentioned impaired consciousness in 7.5%. Which in my own experience, as well as probably many people in this audience, I think is exceptionally low. Seizure was rare in only one patient, and I think this definitely caught my attention as well as the world. There were 6 patients that had stroke, so in their group, 2.8%, of which 5 were in severe patients and 1 was in what they would call a non-severe case. So this kind of put it on the radar, but there wasn't much in terms of detail about these patients. The next paper that came out shortly after specifically talked a little bit more about details of these patients. So another preprint that then was eventually published looking at the January to kind of February experience in Wuhan. Here they had 221 patients and they had 11 that had acute ischemic stroke. So that's 5% of their population, 1 that had a venous sinus thrombosis and 1 with an intracerebral hemorrhage. Here, they noted that those that had cerebrovascular disease were older, so on average 71.6 years, compared to 52 years in those that did not have a stroke during COVID. They noted that the patients were more likely to have severe COVID and more likely to have cardiovascular risk factors, so hypertension, diabetes, or a history of prior stroke. The mortality for these patients was very high, so 5 of the patients died, which was 38% of that group as of the time of publication. So for the next few slides, I'm going to talk specifically about my own experience at Boston Medical Center, because we're certainly, I think, kind of a model paradigm for understanding what was and what is happening at the time in urban American centers and now really across the world. And so our paper, this paper, and then the one that I'll talk about next, was really about what happened in that first wave or peak. So in March through May of 2020, we treated 2,729 patients with COVID at our safety net hospital. The patients were largely from minorities, so 75% are Black and Hispanic. And in particular, Hispanic patients tended to be admitted. As we've seen worldwide, we found far more men that were hospitalized with COVID than women, in particular in our ICU. So almost twice as many men were ICU admitted than women. Patients that died tended to be older. So greater than 80% of our patients that died were over the age of 60. Certainly, they had many medical conditions that are frequently associated with the need for hospitalization. So what we saw was that frequently our patients had chronic kidney disease, on hemodialysis, CHF, COPD, CAD, diabetes, hypertension, and in particular, those comorbidities were seen in those that died. Notably, we also cared for almost 17% of the patients that we cared for at the time were homeless. So that just kind of gives you a sense of the population that I'm going to be talking about. So together with my partner, Dr. Priya Anand, who's my partner in neuroinfectious disease, we created a prospective registry of patients that were followed either by neurology or by neurocritical care. Our IRB was approved on the 15th of April, so we tracked patients really through what we would call the first wave, which we kind of ended at July 1st. All the patients were either admitted to neurology, neurocritical care, or consulted. And so here, our patients really were very similar to the overall BMC COVID population at the time. 57% were male. The median age was 64, although you can see there was a pretty wide range there. And Blacks and Hispanics made up 73% of our consults, which were similar to the overall population at the time. 18% of the patients came from facilities and 11% were homeless. So it's not a surprise then that the majority of our patients use public health insurance options. Very notably, about half of the patients that we saw were critically ill, though we likely under-included patients because at the height of the pandemic, the neurocritical care team formed part of the ICU COVID surge team. And so they didn't necessarily consult, for patients that were encephalopathic and maybe even not necessarily for stroke. So just to describe those patients, similar to other patients that were admitted with COVID, those that had neurologic complications frequently had vascular risk factors, hypertension in over half, as you can see atrial fibrillation in 43%, diabetes, hyperlipidemia, smoking in a third, chronic kidney disease in a quarter, and HIV in a quarter. And so patients with neurologic complications frequently also had a history of neurologic conditions, most notably stroke. So 1 in 5 of the patients that had a neurologic complication when they were hospitalized for COVID had a history of stroke, I think, which is pretty important. Patients with neurologic symptoms less frequently reported kind of the typical respiratory viral complaints such as cough or dyspnea or fever, and even fewer had the kind of GI type presentation. Neurologic symptoms were very frequent at presentation, even if that's not why we ended up being consulted on the patient. So when you look back at, admission to the hospital or in the emergency room, over half of them had alterations in their mental status. In terms of the diagnoses we saw, the most common diagnosis was toxic metabolic encephalopathy, which is probably not surprising. But in particular, I think it's notable that a lot of patients had uremic encephalopathy. And these weren't just in patients with a history of chronic kidney disease. I think a lot of us know that very severe COVID patients often develop multi-system organ failure and end up needing dialysis. So this is not that surprising. 30% of the patients that we were consulted on ended up having cerebrovascular disease. And so I'll go into those in more detail in a few slides. And 20% of the patients that we consulted on were for seizure. Patients with neurologic complications tended to have some disability at baseline. As I mentioned, a lot of the patients had a history of stroke, so it's not surprising that the baseline median MRS was 2. Those that survived had worsened disability with the median MRS of 4. Most of the patients were discharged to facilities, with only 20% going home without services. And 14% of the patients that we saw with neurologic complications died in the hospital. I think for sake of time, I'm going to skip ahead to actually talk about stroke. And if there's a little bit more time and interest, we can kind of go back to talk about some of these non-stroke complications. All right. So obviously we saw a myriad of different cerebrovascular complications, really the entire range. Mostly ischemic strokes, also saw intracerebral hemorrhage, patients with encephalopathy that on their imaging had, leukoencephalopathy, oftentimes with microhemorrhages. And this has been reported in a lot of places where, for whatever reason, there's also a predilection for some microhemorrhages within the splenium. We saw patients with venous sinus thromboses, with PRES, and with RCVS. And I'll talk about a few of those cases in particular, I think out of interest. So in terms of acute ischemic stroke, we saw 14 patients with acute ischemic stroke in that first wave, which was 1.5% of the overall COVID-19 population. So the mean age and sex really matched similar demographics to who was in the hospital at the time. The mean age was 64, and 53% of the patients that had strokes were males. Just over half the patients had a history of hypertension, 37% with diabetes, and a quarter of them were smokers. But very notably, there were no identifiable vascular risk factors in 21% of these patients. In terms of the stroke mechanism, most of the strokes that we saw were considered cardioembolic, including 3 that we would consider ESIS. And the majority of the patients spent some time in the ICU. Because these were very severe strokes, including large vessel occlusions, it doesn't surprise me that because of the stroke alone, they might have spent time in the ICU. But I can't say which breakdown of patients were in the ICU because they had a stroke and which number of patients were in the ICU severely ill with COVID and then had a stroke. The mortality, as I will mention in other studies as well, was pretty high. 5 of the patients died, so this was 36% of the group. And I'm going to talk a little bit more about some of the other interesting observations we made about cerebrovascular disease. So we had 2 interesting cases that were consistent with PRES pretty early on. So we decided to publish our experience together with some cases that we found in the literature. So as I think a lot of this group, right, has taken care of patients with PRES, and most of those cases, right, are associated with hypertension. We hypothesize that endothelial dysfunction and perhaps cerebral hyperperfusion, is what leads to kind of leaky vessels and the appearance of PRES. But in contrast, the majority of the cases in our series of COVID with PRES actually had very modest blood pressure fluctuations. And in particular, the 2 patients that we took care of that had PRES were treated semi-experimentally, if you will, for COVID infection with interleukin inhibitors. So one with the IL-6 inhibitor tocilizumab, and the other with IL-1 inhibitor anakinra. Both of these have effects on the endothelial function, and tocilizumab in particular has been reported to cause PRES or be associated with PRES rather in other studies. So it is, a potential that it's these treatments that are associated with developing present COVID-19 and not COVID-19 itself, but who knows, just a very small case series. Another kind of cerebrovascular complication I think is important to note is venous sinus thrombosis. And so we had 3 cases that we saw at our medical center, all women. And of course, that's interesting because overall COVID-19 seems to be more severe in males, although at the same time, venous sinus thrombosis is more common in women in general, even outside of COVID. So perhaps that's what we're seeing here. So we had 15 cases, including ours and those that we saw in the literature. Some things to kind of note: there was a female predominance, as I've mentioned. The age range was quite wide, from 25 to 79 years of age. There's a lot of variability in the timing of presentation. So some patients had venous sinus thrombosis that were diagnosed at the time of their admission for COVID-19. Others were admitted for COVID-19, returned home, and came back with a venous sinus thrombosis. Most, I think, very importantly, especially if there's any trainees on the call, most of the patients who just presented with headache. They didn't present with focal deficits. They didn't, present with coma, though some have had some degree of encephalopathy. And it's really important, right? Because so many patients that have COVID present with a headache. Women tend to have primary headache disorders like migraine. And so it's very difficult to kind of tease out which are these patients that have a headache in COVID because they've got a venous sinus thrombosis, and who have an exacerbation of their, chronic headache disorder, and who just have headache because it's part of a viral syndrome. So definitely, keep on the lookout for these patients. A lot of patients did end up having seizures, but all of them occurred after the time of their diagnosis for venous sinus thrombosis. Though our 3 patients survived, 4 of the patients reported in the literature died. More recently, we published our experience with RCVS. So we got together with some of our colleagues at other centers to put together 10 cases, 7 of which were women, not surprising since these seems to happen as well, more frequently in women, with pretty wide age range, so anywhere from 20 to 60 years. 7 of them had a history of vasoactive agents that could have provoked RCVS, and 2 had a history of migraine, which may have been a risk factor for developing RCVS. So the majority of the patients, 9 of the patients, had typical kind of COVID symptoms. So this was not like an incidental, they had COVID, positivity and then came in for RCVS without any other syndromes. Most of them, symptoms rather, most of them did have kind of a consistent COVID syndrome. MRIs showed, as you can see on the imaging there, a variety of findings. So 3 had subarachnoid hemorrhage, 2 had intraparenchymal hemorrhage, 4 had ischemic strokes, and flare hyperintensities were seen in 2 of them. In terms of the vessels, focal segmental irregularity was seen, and narrowing that were concerning for vasospasm in the left MCA, actually, in 4 of the cases. And then diffuse multifocal narrowing was seen in 6 of the cases. Outcomes were variable. So 2 patients died, 2 were in the ICU at the time of publication, and 6 survived to discharge with modified Rankin scores of 0 to 3. And a lot of people would say, well, is this just kind of an epiphenomenon? RCVS, isn't that uncommon at a comprehensive stroke center, and COVID right now is raging. And it's very possible that actually is the case. I also think, and we're going to talk a little bit about stroke mechanisms in a few more slides, SARS-CoV-2 definitely causes endothelial dysfunction. And if endothelial dysfunction, is part of the pathophysiology for what happens in RCVS, even though other viral infections have not been known to trigger RCVS, there perhaps could be, I think is very plausible rather, that SARS-CoV-2 infection could perhaps, contribute to developing RCVS in some patients. But I think more of this remains to be seen. So shifting gears here, I know it's a busy slide with a lot of information, but I wanted to highlight kind of some of the themes from reviewing these really early studies about acute ischemic stroke in COVID. But it's notable to say most of these studies that we're all talking about are retrospective, and they're all kind of single center studies. So the ones I have included here are single center or single healthcare system. They're from the spring last year in China or urban American populations. And so when thinking about the incidence of stroke, at least from these studies, it's anywhere from 1% to 5%, which is fitting in line with my own experience. Most of the time, strokes were seen in males, and in the studies in the United States, there seems to be an increased risk in Blacks and Hispanics, but again, that could also reflect the demographic of who was admitted with COVID and who was affected by COVID, especially early on. age was all over the place. So some reported younger patients, and others said that they were really in a typical kind of age range. Many studies reported that patients had typical cardiovascular risk factors, but not all. And overall, strokes were far more often to be considered large vessel occlusions than other types of etiologies. And there were many cryptogenic strokes reported as well. The mortality when reported was very high, so anywhere from 25 to 44%. Kind of moving up the chain in terms of level of evidence here, I'll present to you a couple meta-analyses I think that are interesting. So this one in particular put together 39 studies, again, from very early on. So before, COVID patients were even, being readily identified in December of 2019, all the way kind of through what in a lot of places was the first wave of COVID. So here they identified 135 COVID positive stroke patients. So their incidence that they saw was 1.2%. And the mean age that they saw there, was in the 60s with a wide range. I think what's interesting from this paper is that they talk about the duration of the time of stroke diagnosis relative to their COVID-19 symptoms onset. And so what you see here is that on average, the mean duration was 10 days after their COVID started, although you can see quite a wide range. So, up to 8 days plus or minus. The NIH stroke scale was very high. So on average 19, though again, a wide range. And they described elevated D-dimers, fibrinogen, and antiphospholipid antibody presence in many. Not surprisingly, if you think about the NIH stroke scale, a lot of large vessel occlusions were noted in this patient group. And oftentimes patients also had multiple vascular territories involved. The mortality in this group was 38%. Moving on to another meta-analysis, which again, looks kind of very similarly at this same date range. So I imagine a lot of the same patients may be represented in both of these meta-analyses, but this one included far more stroke patients. So they looked at 30 studies for a total of over 55,000 patients and had almost 900 identified with stroke. So what they looked at here, they found that the average age for COVID and stroke was 65, but really the range there was 40 years. The incidence of stroke was slightly higher, but again, we're not talking slightly higher, meaning 5%, we're talking 1.74%. And mortality in this group was about 30%. One more meta-analysis that I think is interesting to look at. So here, again, they looked from December of 2019 through September of 2020, so a little bit longer duration. And they had 61 studies that they reviewed here. And so amongst over 108,000 patients with COVID-19, they found an incidence of 1.4% with stroke, of which the majority were acute ischemic strokes and far fewer were intracerebral hemorrhages. And so what they found is that patients that had COVID and developed strokes tended to be older than your average COVID patient, with a median difference of being older by 4.8 years. These patients were more likely to have underlying vascular risk factors, so hypertension, diabetes, coronary artery disease, and were more often to have severe infections. They also highlighted 11 studies, which I think is very interesting. So they looked at patients who had stroke and COVID, so they had 395 of those, and patients that had stroke during that time period that did not have COVID, and obviously they had a greater population of those, 1,670. And what they found is that those that had stroke and COVID were younger on average than those that did not have COVID by 6 years. They're much less often to be female, more often had a higher NIH stroke scale that would correspond with the fact that they had more often large vessel occlusions and much higher mortality. They're also less likely to have vascular risk factors such as hypertension and prior stroke, although the other risk factors such as diabetes, hyperlipidemia, smoking, coronary artery disease, and atrial fibrillation were similar in these groups. So kind of shifting gears here, and I think what a lot of people were feeling kind of after looking at, small case series, which I myself have written several of, to meta-analyses, we really need, prospective data. And so we participated in the GCS Neuro-COVID study, which was really kind of the largest and first prospective study to be reported. So they had about 3,500 patients. And it's an interesting study. There were 3 cohorts included in this. So 2 were all neuro cohorts, meaning the patients that were included had to have COVID, obviously, but also neurologic symptoms. And one of those was international, another was purely European. And then the third cohort was a group of patients that included some that had neurologic complications and some that did not. And what we found here was that even amongst the group that included patients without neurologic complications, 80% of those had some sort of neurologic manifestation, so something reported like a sign or symptom in addition to a clinically verified sign or syndrome. And when you look though at just things that a healthcare provider, for instance, could recognize, 53% of those in the all COVID group had a neurologic complication, meaning a neurologic sign or symptom that could be found. When you look in particular at stroke, amongst the neuro-only cohorts, stroke represented a lot of these diagnoses, so almost about 20%. And when you look at the all COVID group, the incidence of stroke there was 3%, so higher than I think has been reported in some of these meta-analyses. When you look at incidence of neurologic manifestations, I think there's some interesting things to be seen here. So when you look at all comers with any neurologic manifestations, so this could be a complaint like a headache or dizziness, as well as a sign or syndrome such as having coma, for instance, or having hemiparesis, you don't see a difference in terms of the age groups for those any neurologic manifestations. But when you look at clinically captured signs and symptoms, what you see is that there's definitely a relationship there with age. So increase in age is associated with more likelihood of having a clinically captured sign or syndrome. What you see here as well is that's very similar specifically for acute encephalopathy, stroke, and COVID. What you also see is that seizure, meningitis, and encephalitis are very rare, so less than 1% in these groups. In terms of, they also looked at things that might be associated with risk of death. And certainly what was seen there is with increasing age, there's an increasing risk of death. Certainly also being male increased the risk of death. And then whether you had a neurologic manifestation or clinically captured signs or syndromes, all of those were associated with an increased risk of death. Though very interestingly, acute encephalopathy and coma, as you might expect, would be associated with an increased risk of death. What they found specifically for stroke here was that it was not, which I thought was very interesting. So kind of putting that all together, here's kind of the breadth of neurologic complications that I've seen reliably reported. So if you include common non-specific symptoms such as myalgias, fatigue, headache, and then certainly anosmia and dysgeusia, which have gotten a lot of press, up to 88% of patients have some sort of neurologic manifestation of COVID. But certainly, we've talked a lot about the acute complications, including stroke. I think in the end of the day, the incidence of stroke and acute COVID is probably going to be less than 2%. And certainly, there are para and post-infectious complications that happen in COVID as well, but these tend to be, less common. But the last slide alone doesn't tell the whole story, because it seems that COVID is associated not just with the development of acute neurologic complications, at the time of having COVID, but also there must be some risk that extends for some period of time afterwards. And so when you look at this meta-analysis, sorry, not a meta-analysis here. When you look at this retrospective study that had a ton of electronic health records, what you can see, and they broke it up here by patients that were not hospitalized, patients that were hospitalized, and then patients that were hospitalized, for instance, and were admitted to an intensive care unit or encephalopathy. If you look at that group with encephalopathy, almost 10% developed stroke in the 6 months following COVID, which I think is just incredible. But even those who are not hospitalized, 1.33% developed stroke within 6 months. And so it doesn't surprise me when you look at literature, for instance, with influenza or with having shingles, for instance, that having some sort of infection does seem to increase your risk, probably because of some sort of inflammatory state. In the following 6 months, we don't know yet, probably up to a year. We just need more information about that still. So it'd be remiss to not mention long COVID, or what we're calling the post-acute sequela of COVID. For those of you that are not familiar with this, what's typically described is persistent severe fatigue, headaches, what people call brain fog, which is cognitive impairment, mood disorders, sleep disorders. And these are symptoms that persist for greater than 4 weeks after having an acute illness. And what's really important is that this is independent of acute illness severity. So we're not just talking about a post-ICU syndrome, for instance. In fact, this is most often happening in people that were never hospitalized to begin with. Overall, what we know so far about long-haul COVID, which is not much, is that with extensive kind of standard diagnostic workups, really most patients seem to have normal or very non-specific types of findings. There's not been a lot, obviously, out there yet describing these long COVID cohorts, but there is a clinic, probably the best known clinic at this point is the post-COVID clinic at Northwestern. And so they reported about their group, and what was seen there, which I think is being reported, widespread, is that this seems to be happening more often in women and men. So in their group, the ratio was 2.3 to 1. And many of these patients had pre-existing autoimmune diseases or had high ANA titers. So obviously this suggests that there may be sort of some post-infectious autoimmune etiology for these symptoms. A lot of patients as well had premorbid depression or anxiety. So for instance, in that group, there was a 40% prevalence, which is almost double what is seen in the regular United States population. There are a lot of similarities being discussed between long COVID and the myalgic encephalomyelitis or chronic fatigue syndrome. And many patients also have features that are similar to POTS in terms of having dysautonomia. This is a really important illness that we need to know more about. And it's hitting people in the prime of their working lives. And so I'm very happy that the NIH has really committed over $1 billion for past research, which is starting with this Recover program, which hopefully I'll get to tell you a little bit more about at the end of the talk. So shifting gears here, talking about mechanisms or pathophysiology, I wanted to remind you of the pathogenesis for SARS-CoV-2 infection, because it helps understand how neurologic complications can happen. So on the left is what you're seeing here is the process of how SARS-CoV-2 endocytoses. So obviously the virus uses this famous spike protein to bind to the ACE2 receptor. And in the process of endocytosis, this ends up having downstream effects on the renin-angiotensin system. And I'll mention that again in a few slides. On the right here is a reminder about tissue expression of ACE2 receptors, because this is really what determines viral cellular tropism. So obviously the ACE2 receptor is found in respiratory and vascular epithelium. This is why it causes severe respiratory illness and ARDS. It's also found in the GI tract and kidneys and widespread through the CNS. So certainly there's the potential there for direct kind of involvement of the CNS. There's really three main categories how neuropathogenesis of SARS-CoV-2 infection can happen. So certainly direct CNS invasion. So it could be that there's retrograde axonal transport, but also if you think about the slow flow that we know happens in the cerebral capillary beds, if the vascular epithelia have ACE2 receptors, there could be, direct infection through there. Certainly systemic issues such as coagulopathy, inflammation, or the so-called cytokine storm can be contributing to why people get neurologic complications in COVID. And then obviously multi-system organ failure, hypoxemia, general critical illness, all of these things can contribute to developing neurologic complications. And then just like every other infection, there could be para-infectious or immune-mediated complications that occur. In terms of evidence about neuroinvasion, so coronaviruses are neurotropic, and there has been some radiographic and pathologic evidence of this. So on the left is an MRI from a radiology tech who developed acute onset of loss of taste and smell. What you can see is that she had MRI abnormalities within the olfactory bulbs and the adjacent right gyrus rectus, which resolved at 28 days, although arguably her olfactory bulbs are a bit thinner. On the right is just a schematic, that could show that the virus could enter the CNS through axonal transport. Obviously, the virus being very present within the nasal epithelium, it can attach to the olfactory nerve, go through the cribriform plate, and that is certainly why loss of smell is one of the first symptoms that can happen to many people with COVID. In terms of neuropathology, it's really shown mixed results. So what I can tell you for sure is that neuropathology is not, despite what I mentioned about the ACE2 receptor expression throughout the CNS, we're not seeing brains with a ton of invasion, viral invasion from the brains. All of the brains that have been looked at do have inflammatory changes, many of them with infarcts, including those that were not seen pre-mortem, but detection of SARS-CoV-2 itself has been variable. So in a German study that was published in Lancet Neurology, 21 of the 43 patients that they had viral protein seen on cranial nerves and in the brainstem, but we're not seeing kind of widespread throughout the brain. On kind of the lower left, through anti-spike immunohistochemistry, they were able to detect some cortical neurons, and then very appropriately, we're also able to see it in the endothelial cells around infarcts. In terms of stroke, there's many possible ways in which SARS-CoV-2 infection can lead to stroke. I think the first kind of most plausible is that a general systemic inflammatory response can result in rupture or erosion of an atherosclerotic plaque, which was just previously asymptomatic, right? We also know that there's viral-mediated hematologic derangements and hypercoagulable state. The SARS-CoV-2 infection indirectly leads to activation of the renin-angiotensin system that has downstream consequences that increase risk for stroke. COVID can be associated with the hyperinflammatory conditions and cytokine storm. Certainly, cerebrovascular complications can occur secondary to COVID treatments, as I mentioned earlier. General critical illness, we know, always can lead to stroke. There's specific cardiac effects, such as myocarditis and stress cardiomyopathy, with or without atrial fibrillation. And we know, for instance, sepsis often is a trigger as well for atrial fibrillation. Certainly that predisposes to stroke. There's a lot of really interesting growing evidence that SARS-CoV-2 infection can lead to an endotheliitis or a vasculitis. And I think that this is actually an area that is really important to look at. And then finally, there are some cases that patients will have spontaneous cervical artery dissections as a result of frequent coughing. So I want to briefly highlight COVID-associated coagulopathy, though I think there could be a talk devoted just to this phenomenon. So people often compare it to DIC, but there's some distinct differences. So notably in the initial phase, COVID-associated coagulopathy is characterized by elevated levels of fibrinogen and an elevated D-dimer, but platelets and the other coagulation parameters tend to be normal. Later on, some can evolve into a DIC type picture where their platelets drop as well as their fibrinogen. And when they develop that type of picture, it's associated with far worse outcomes. Of note, very high D-dimer and FDPs are associated with high mortality. Thromboemboli in COVID tend to be overwhelmingly venous. And depending upon whether you're doing screening Dopplers or whether or not you're looking for a clinical DVT, there could be as much as 70% of ICU patients, for instance, with venous thromboemboli. The hallmark of COVID-associated coagulopathy is microvascular injury. And this may actually, in the lungs, be part of the pathogenesis for developing ARDS. Very briefly, I wanted to mention an interesting finding that's been reported in several papers. So the bottom three studies are looking at patients with COVID, not patients with COVID and stroke, just populations of COVID patients. And I think it's important to see that in these patients, a lot of them had the presence of a lupus anticoagulant or antiphospholipid antibodies. So we have to keep that in mind when looking at the top three studies, which are case series that have been reported, because these are patients specifically with COVID and stroke that also have the presence of lupus anticoagulant or antiphospholipid antibodies. So it's very difficult to know if this is coincident or if this is causal, but certainly something to keep in mind. There's a lot of evidence of hyperinflammatory states that occur in some COVID cases. SARS-CoV-2 can bind to toll-like receptors, which essentially activates what's called the inflammasome. The profile of cytokines in severe COVID is very similar to that described in HLH. So for those of you who aren't familiar with that, HLH is the hemophagocytic lymphohistiocytosis, which is a mouthful to say. But what it is a hyperinflammatory response that happens often after a bacterial infection or in cancer. Having rheumatologic disease or immune deficiencies can also provoke this. And the clinical picture seen in HLH is high fever, rash, LFT abnormalities, so they often have jaundice, pancytopenias, lymphadenopathy, and the lab findings are often that they have extremely elevated ferritin. So there's a lot of thoughts that this systemic inflammatory response and not the viral infection itself that could be responsible for stroke, in particular in young patients without vascular risk factors. As I mentioned, SARS-CoV-2 has downstream influence on the renin-angiotensin system. Because it uses that ACE2 receptor to endocytose, it leads to downregulation of ACE2. That ends up underacting the RAS alternative axis, and that ends up overactivating the classic RAS axis. So that would this would lead to increases in ANG2, which would cause vasoconstriction of the, which could include the cerebrovascular as well. You could have raised elevations in your blood pressure, and this could trigger a pro-inflammatory state as well. There are obviously cardiac specific effects of SARS-CoV-2 infection. So myocardial injury is thought to occur in about 1/5 of hospitalized patients with COVID. And so other kind of things that have been described in COVID are stress cardiomyopathy, which could predispose to stroke, and then obviously atrial fibrillation. Finally, there's growing evidence of injury specifically to the vasculature. And so there's endotheliitis that can occur systemically as well as just specifically in the cerebrovasculature. On the top right there is a study that really scares me. So it's a group from Switzerland, and they had 120 patients in the ICU during their first wave, 5 of whom had a prolonged encephalopathy with really a very negative workup. They decided to do vessel wall enhancement. And what they found is despite a normal, or I guess a negative MRA, there was enhancement of the basal skull vessels without any other kind of vasculopathy appearing on their traditional, angiography. CSF was negative, and they did systemic imaging as well and found that many of them had diffuse enhancement of vascular wall, so renal, hepatic, iliacs. They gave the patients pulse dose steroids, and it was nice to see that for these cases, there was improvement. Notably, these patients didn't have any cutaneous signs of vasculitis. On the left is some pathology from a different group here. And what they're showing on gross pathology is a microhemorrhage. They also did a post-mortem MRI, and on the SWY sequence, you can see a lot of those microhemorrhages that I had mentioned earlier that seem to be the hallmark of what occurs oftentimes in a severe encephalopathy. On the micropathology, which you see here on H&E, is fresh hemorrhage, and then certainly there's evidence of diffuse intravascular microthromboses and endotheliitis. Another study, which is this one I mentioned here, the vessel wall imaging in COVID-19 patients with cryptogenic ischemic stroke, whereas I think a lot of cryptogenic ischemic stroke is going to be blamed on specifically a hypercoagulable state alone. It seems that some patients that have vessel wall imaging do actually have an evidence that suggests this endotheliitis. So definitely something to be on the lookout for. From a practical, moving on to this. So in terms of what has been described for COVID-19 stroke etiologies, so the group with SVIN looked at 156 patients with COVID and stroke. And what they found is the majority were men, most of them were white, and most of them were within the ages of 60 to 79. And they found that 42.6% were determined to have cryptogenic stroke. Patients with cryptogenic stroke tended to have higher white counts, higher CRPs, and higher D-dimers than the non-cryptogenic patients. They often had higher baseline NIH stroke scales, and having a cryptogenic stroke versus other etiologies of stroke was an independent predictor of mortality. And so getting to kind of my practical recommendations for working up a stroke patient, obviously you're going to do your traditional vascular risk factor evaluation, your echo. I do send a hypercoagulable panel, though I know there's a lot of controversy when I talk to my hemonc colleagues about the utility of this, especially if you find transient things like antiphospholipid antibodies and lupus anticoagulant. There may be an argument to do vessel wall imaging on MRI for some patients. Certainly, if you find any evidence suggestive of vasculitis, which I think has been reported and we've seen at least once, there may be utility then for a conventional angio. And CSF studies really have shown a paucity of inflammatory changes in most patients that have COVID and neurologic manifestations, although those with stroke are more often to have inflammatory changes. And so oftentimes we may not be able to get an LP in a patient that's had a very large territory stroke because of concern of mass effect, but there are probably some cases where CSF studies may be helpful. And so I've gotten a lot of questions about this recently. So what about COVID vaccine related stroke? And so the COVID vaccine related stroke that we know about most commonly is what's called the vaccine induced immune thrombocytopenia and thrombosis. So this has only been seen associated with the adenovirus vector vaccines, which in the United States are Johnson & Johnson, and in Europe is AstraZeneca. The pathogenesis of this is very similar to HIT, though patients were not exposed to heparin. There are high titers of antibodies seen to platelet factor 4, and that is actually what's associated with activating the platelets. This was initially described as just being associated with venous sinus thromboses and only occurring in young women. But in the New England Journal series of 220 patients, there was no predilection for sex and a very wide age range. As we've reported, as well as others have, it can cause acute ischemic stroke, so not just venous strokes. But again, the incidence of this is very low. So in those less than 50 years of age, the incidence is supposed to be 1 in 50,000. So what about mRNA vaccine related stroke? And so certainly there's been, and this was reported in JAMA last month, surveillance for events after the COVID mRNA vaccines. And so when they did their interim analysis of surveillance data, They looked at the first 21 days in this patient population, or I guess in this patient population, compared to that same population in days 22 to 42. So not comparing those that got the vaccine to those that didn't get vaccine, but those who had vaccine early, like what their events were early compared to later. They had 6.2 million persons, so that included 11.8 million doses of the vaccine. And they looked at incidence per million person years during the risk period versus the comparison intervals. So looking specifically for at the adjusted relative risk for ischemic stroke, the relative risk was less than 1 for this patient population. So that's good news. That's very reassuring. They did have 10 cases of venous sinus thrombosis that were reported, though none were associated with thrombocytopenia. So VIT does not appear to occur with the mRNA vaccines. And so the bottom line is that acute ischemic stroke could follow COVID-19 vaccination. It could be a coincidence. There could be, in a very small number of patients, some sort of relationship, but it is far more common with COVID-19 infection itself to develop a stroke than with the vaccination. So I do not think at all this is a reason to not get a COVID vaccine. Moving on to kind of treatment phase, I'll briefly discuss data about treatment for stroke and other coagulopathy. So early on, there were some concerns that SARS-CoV-2 could be associated with increased bleeding. There was reports of necrotizing hemorrhagic encephalopathy, or perhaps there were also concerns that hypercoagulable state was so severe that TPA didn't have any effect. So very early on, we did a multi-center case series with 13 patients from 8 centers. Some interesting points of that, just that were 70% of the patients were male. The strokes were fairly severe with an average NIH stroke scale of 14. And very notably about our series, all of these patients were in the community with COVID. And so therefore, we're not talking about a group of patients who were severely ill in the ICU with COVID for 2 weeks. These are people out in the community. TPA and thrombectomy in our series, as well as others, have shown that TPA is efficacious and was not associated with higher bleeding risk. And so we participated as well in the larger study, the Cascade Initiative, where we looked at a lot more patients. We had 101 patients with COVID. And essentially kind of the bottom line is that IV TPA treatment in patients with acute ischemic stroke and COVID-19 was not found to be associated with increased risk of disability, mortality, or hemorrhagic transformation compared to those without COVID-19. So between this, and I'm not going to go through, kind of the details here, but between our papers looking specifically at TPA and many papers looking specifically at thrombectomy, all of the literature unanimously has shown that IV TPA and thrombectomy are safe in this patient population, and they are efficacious. So we really shouldn't treat patients with large vessel occlusion and COVID, any differently, except for obviously to have the appropriate PPE for us who are treating them. In terms of primary prevention of stroke and COVID, right? So we know that stroke happens in perhaps 2% of patients or less that have COVID. So how do we prevent that in this hospitalized population? Certainly prophylactic anticoagulation should be given to everybody that has an elevated VTE risk. And there are certain populations, those that are considered to have symptomatic COVID that are hospitalized but not in the ICU, that would benefit from therapeutic anticoagulation. Some groups stratify by the D dimer, and those that have markedly increased D dimer, because this is associated with high mortality, will have anticoagulation. But the million-dollar question is, does the anticoagulation strategy help to prevent strokes in patients? And so there's no study that specifically looks at this, but we can try to kind of tease out this question by looking at some other studies that have been published. So we participated in Active 4A, and that was part of 3 independent international trial platforms where they looked at hospitalized adults with symptomatic COVID-19, and they randomized them either to unfractionated heparin or low molecular weight heparin at treatment dose versus the prophylaxis dose. And that was either for 14 days or when the patients were liberated from supplemental oxygen. They had over 2,000 patients at the interim analysis. And the bottom line was that therapeutic dose anticoagulation with heparin was associated with reduced use of cardiovascular or respiratory organ supports, basically needing to go to the ICU for a vent or for pressors, an increased probability of survival compared to using usual care thromboprophylaxis. So based upon this study, we changed to virtually anticoagulating at a therapeutic level all of our what we would consider symptomatic COVID-19 patients. When you look at the details though, did this help for stroke? And what you see here is that certainly this is probably not unexpected, right? Those that had therapeutic dose anticoagulation had far few major thrombotic events than those that received just prophylaxis dose. It's also not surprising though, that patients that got therapeutic dose anticoagulation had higher bleeding risk than those with usual care thromboprophylaxis. And one of the things that was interesting at this interim analysis and why it did not continue, besides the point that they met their primary objective, it was very underwhelming with the number of events that they had. They really did expect that there would be far more events in both of these groups. And so I would really love to see some sort of subgroup analysis, for stroke. But when you look at these events in general, it's so low that my guess is that most of these thrombotic events that they're talking about are going to be, going to be DVTs or MIs and probably not stroke. So this alone doesn't answer it. Even more confusing, there's this meta-analysis essentially of randomized control trials that looked at escalated dose. So these are patients that either get the intermediate dose of heparin or they get therapeutic dose of heparin versus prophylactic dose. And they included critically ill and non-critically ill COVID patients. They had 7 randomized control trials that were included with over 5,000 patients, and they studied them for 33 days. And basically what they found in this study with the escalated dose anticoagulation is that there were lower rates of DVTs, but there were increased rates of major bleeding. Very interestingly, and I know you probably can't see the numbers on here, but at least you can see the trend here. There was no significant effect on MI or on stroke. And there was no reduction in all-cause mortality. So this is a bit disappointing. And I think that the jury is still out. Of course, decisions can never be straightforward as well. I mean, currently we're giving therapeutic anticoagulation in our hospital to everyone with symptomatic COVID, but there are risks here, and I'm not going to go through kind of all of the details here, but suffice to say, some of these studies helped identify what are increased risks for having intracerebral hemorrhage, certainly increases in age, being non-white, mechanical ventilation, which is really a proxy for critical illness, and therapeutic anticoagulation in one study was associated with a 5-fold increase in risk. So obviously it does not come for free. And this comes to the next kind of $1 million question, in stroke and COVID. When you have a patient that's had a stroke in the setting of COVID, what do you do to prevent the next one? So obviously you're going to do a standard workup, and I would say standard recommendations apply if an etiology is found, right? You have atrial fibrillation, that's an indication for anticoagulation. Otherwise, you could consider DAPT in the appropriate context. But what about all of those patients with cryptogenic stroke? Because before COVID, my practice has always been antiplatelets, do your 30-day workup. If you find a cause, later to anticoagulate, then you anticoagulate. Otherwise, we're kind of just waiting to see if something else happens. I feel very differently in COVID-19, and my opinion, which that's what it is, it's an opinion, it's not based on a tremendous amount of evidence, is probably to favor anticoagulation in these patients with cryptogenic stroke. But after the call, if people are interested in talking about that, I'd love to hear your opinions as well. I think a lot of my thoughts about this have to do with another question, which is another $1 million question, which is, what is the duration of the hypercoagulable state in COVID-19? And I can tell you, nobody knows that. But there's some interesting papers, I think, that might shed a little bit of light on this topic. So on the right is a paper I already told you about, right? So it seems like there may be some increased risk in having stroke, at least in the 6 months following COVID. On the left is a self-controlled case series that was done in Sweden. And so they looked essentially at two outcomes. They looked at MI and they looked at acute ischemic stroke following a diagnosis of COVID. And essentially what they found there was that the incident rate ratio for acute ischemic stroke in the first week was over 6, in week 2 was 2.85, and in weeks 3 and 4 was 2.14. But what we don't know is, when does that go to 1? When do you go back to having your routine kind of risk of stroke? And we don't know the answer to that. But I think it's a really important question that we need to have answered. So in terms of what's next, I have a lot of questions. So what is the true incidence of stroke in COVID-19? We don't have humongous prospective, observational data of this, but I'd be surprised if it ended up being, greater than 2%. I think it's important to know whether their stroke risk actually changed with each SARS-CoV-2 variant, or do we have different information because the populations being affected at different time points may be different. I think it's important, we need to know if COVID-19 increases the risk of stroke independent of vascular risk factors. And I think there's definitely some evidence that in some patients it does. We don't know enough about if anticoagulation is protective for stroke, who should get it, for how long, what type of anticoagulation. Again, it's controversial, my advice about anticoagulation for cryptogenic stroke in COVID. And does stroke increase the risk of death in COVID, or does having a stroke during COVID occur just because COVID is severe? So we don't really have answers to that. We can tell you about a study that we're participating in, which is the Viral Infection and Respiratory Illness Universal Study. This is sponsored by the Society for Critical Care Medicine. BU is one of the main sites, as well as the Mayo Clinic. And we have over 67,000 patients that are in this, including 16,290 patients that are critically ill. I am the PI for the neurologic arm of this study, and I can say the paper is under review right now, so I'm sorry I can't give you any more data about this, but hopefully the study will be published soon, which will be the largest study kind of looking at patients that are hospitalized with COVID-19, and I'll be talking, like I said, specifically about the neurologic complications, risk factors for those, and the impact of outcomes, the impact of neurologic complications on outcomes. We will also be participating in the Recover study, where we will look at kind of the outcomes for patients that have had COVID and have persistent symptoms. Thank you so much for your attention, and I'm happy to take any questions.
That was great, Anna. What a comprehensive, thorough evaluation of the neurologic complications and specifically cerebral vascular complications of COVID. There is one question in the queue. Can you access that?
Oh, yes. Not related to stroke, but what are your thoughts on someone that has anosmia after COVID with no history a year later? I don't have to email you. I'm happy to answer that question. And I'm going to be very personal. So I had COVID last November, and I knew that I had COVID because it was right before Thanksgiving. And I went to go make a pumpkin bread for my kids, and I opened up the cloves and couldn't smell it. And I knew for sure that was COVID, tested positive, etc. I had total loss of my smell. It lasted for several months. Then I thought I was getting some of my smell back. And then last June, set a kitchen fire when I was in the kitchen because I could not smell at all. And I thought, as a neurologist, gosh, November, December, and I started counting out, and I thought by June, July, if I didn't get any of my smell back, the axon should have grown by then. Hopeless, totally hopeless. And I can tell you, actually, in the last month and a half, I've started to get my smell back. So for those of you that have anosmia, I would say don't lose hope. I had kind of lost hope, and I thought that this was going to be part of my regular life, but it's been less than a year, and I'm starting to recover my smell. We don't know enough yet about why anosmia persists in some patients. For some patients, they have had it for over a year, and it may be permanent. There are some thoughts that maybe in some patients, they actually had some degree of loss of smell to begin with, and so they're not recovering it because this is sort of an opportunity to identify that they never had it to begin with. But I think for a lot of people, it's just going to be a very slow recovery process. Good luck.
There is another question there, Anna, you wouldn't mind tackling it?
What about change in smell? Like what used to smell good now smells bad. I'm sorry. Yeah, what you're referring to is parosmia. And there's a lot of thoughts about that. Some of it is this idea that maybe there is kind of a misconnection or kind of a rewiring that occurs when you've lost that sensation. kind of the best advice that I've been given myself personally is to go to your SPICE rack and try to do SPICE training, right? Where you use kind of your vision, if you will, to help correct your brain. You look at your cloves and you remember kind of what cloves smell like, and hopefully it helps to train your brain. In very rare cases, and I don't want to scare everybody who has parosmia, because it's actually very, very common. But in some cases, this is actually represents a partial seizure. And so for some patients that have other symptoms, so not just they go to smell something and it smells different than they think it's going to, but for people that are in their everyday life and all of a sudden have spells of smelling things, almost always that are unpleasant, that also accompany, for instance, kind of severe memory loss. Some of those patients actually are found when you do EEG to have partial seizures. But again, that's the minority.
And then Dr. Schrin asked, how important is obesity per se in neurologic complications of COVID?
Yeah, I think that's a great question, and something that hasn't been looked at, I think, specific enough. So I talked a lot about vascular risk factors, right, that we think, oftentimes come together with obesity. But I can say even in my study that's under review and that we're hopefully publishing soon, we didn't look specifically at obesity. So I think there's a lot of assumptions, but I don't know that data right offhand. It's a good question.
It is kind of scary that they find these unexpected microhemorrhages and small strokes in asymptomatic folks. Do you know, is there any comparison how folks with other type of coronaviruses, like maybe the original SARS or MERS, or what even about just folks with a common cold due to coronavirus? Do those cause similar changes?
Yeah, and I want to mention, I hope I didn't misspeak. So the people that are found to have, strokes that were not detected kind of in life, these are patients that have pathology. So these are patients with severe COVID, right, that have died probably from ARDS. So they may not have had a stroke identified during life. What are being seen on patients who are getting imaged because they have encephalopathy during stroke, a lot of those, encephalopathy during COVID, a lot of those patients are seen to have microhemorrhages and small strokes. So those are thought to be related to their encephalopathy. But I don't know of any studies looking at people who are completely asymptomatic and whether they have microhemorrhages or whether they have small strokes. That I don't know. To your other point, though, is there something unique about SARS-CoV-2? Did this happen, with SARS or with MERS, for instance? And there is a little bit of literature that was published mainly towards the early part of the pandemic, talking about neurologic complications, and they were present in both the SARS epidemic and in MERS, though I don't think that there was as much focus as is being paid to the COVID epidemic, just for reasons of size.
What about
and I don't know your question about a cold. I don't know.
What about the long haul folks? Did their brain MRIs show anything? Is there any correlation with pathology on their MRI in people that have the persistent COVID symptoms?
Yeah, so we don't have enough information, I think, long term, and so that's part of what being in the RECOVER study is about. I can tell you from Igor Koralnik's group at Northwestern, where he had 100 patients. The majority of patients, they either had a normal MRI or they had non-specific findings. So, the sort of things that us as neurologists, when we see patients and we see this one little flare hyperintensity, you don't really know what to do with. I've heard one of my colleagues said you're allowed to have one free for each decade of life. I don't know if that's true. We think that they're associated with vascular risk factors and migraine. I don't know. I think that's largely what we're seeing in COVID patients that have long haul COVID. I have a long haul COVID clinic, and so people will ask me all the time, well, what do you do? Well, when patients come with any of these symptoms, I pretty much treat them like everybody else that come with those kind of symptoms. So I do cognitive screening. If they have vascular risk factors, I almost MRI all of those patients thinking, well, I think that having COVID increases the risk of having stroke. You're coming to me with cognitive impairment or with some speech difficulty or what have, I mean, certainly if they had a focal neurologic deficit, that warrants getting an MRI. And I have had some patients that surprise me that do have very small focal strokes in an area that might explain something that they've subjectively been talking about for the last year. But that's the minority. Most people have findings that I can't explain. They're the scattered kind of flare hyperintensities, or they're totally normal.
Well, that's reassuring in a way. That's
Yeah.
good.
We just don't know.
Well, thank you very much. That was an excellent talk, and I really appreciate you taking the time. I appreciate all your work, and look forward to seeing what else you discover going forward.
Thank you so much. It's been wonderful to be part of this group.
Thanks again. I'd like to thank all of our speakers. It was a great conference. Very interesting, thoughtful talks, and I really appreciate everyone taking their time out on a Saturday. I'd like to thank Mary Chickanowski and Mania McMullen for helping put this together, and especially for Dr. Kate Smith, who really did all the heavy lifting on this. So hopefully next year we'll see some people in person, and maybe we can have a hybrid conference, but we'll see what happens. But just remember, you'll be getting a email to complete the evaluation, which will give you your continuing medical education. Thanks, everyone, and have a good weekend.